Welcome to Perth and Kinross Integration Joint Board meeting of Wednesday, the 30th of March 2022. My name is Bob Benson. I'm the chair of the Integrated Joint Board. I'd like to welcome you all to the meeting today. And before I proceed further, I wonder if I could be updated on any apologies or substitutes. Thank you, Scott.
Thanks, Chair, and good afternoon, members. I'll shortly pass you to my colleague Adam, who will advise of any apologies and substitutes, and we'll take a roll call of members in attendance for the public that are watching. Just before we do that, I just wanted to take the opportunity to remind board members that we're now into the pre-election period for the local government elections, which, although is for councils, it is pertinent to the Perth and Kinross Integration Joint Board and any other public sector bodies. So it's just to remind members that in addition to the Code of Conduct, we're also under heightened rules in relation to any new board member or collectively the board being seen to advocate one political party or another. I'm not expecting that to be an issue this afternoon, but it's just to remind members in relation to any comments or contributions. Can I now pass across to Adam, who'll take a roll call and advise of any apologies.
Thanks, Scott. Just to advise, I've had no apologies submitted for this afternoon's meeting. So, members, when I call your name, if you could just indicate whether you're present in the meeting. Councillor Drysdale.
Present.
Councillor Duff.
Present.
Councillor McDade.
Present.
Councillor Purvis.
Present.
Chair, we've already heard from you, so I'll just skip past. Donald McPherson.
Present.
Beth Hamilton.
Present.
Pat Kilpatrick. Jackie Pepper.
Present, and it's probably worthwhile noting that I'm in attendance today in my capacity as Interim Chief Officer, but also Chief Social Work Officer and Advisor to the IJB. Thanks.
Thanks, Jackie. Jane Smith.
Present.
Sarah Dickey.
Present.
Dr. Sally Peterson. Dr. Lee Robertson. Sandra Auld.
Present.
Lynn Blair.
Present.
Bernie Campbell. Lindsay Glover.
Present.
Stuart Hope.
Present.
Ian McCartney.
Present.
Maureen Summers. And Sandy Watts.
Present.
Thanks, Chair. That's everybody.
Okay, thank you very much indeed. Item 2, any declarations of interest? No. In that case, I'll move on to the minutes and item 3.1, which is the minute of the meeting of the Integration Joint Board of 16th of February 2022 for approval. Can I ask members if they have any comments on the accuracy of the minute before we move to approval? Okay, assuming no comments on accuracy of the minute, can we now move for formal approval? Can I have a proposer and a seconder, please?
I'll propose, Bob.
Thank you. Beth Hamilton.
Councillor Duff, happy to second.
Thank you, Councillor Duff. Thank you. The minute of the meeting of 16th February is now approved. 3.2, minute of special meeting of the Perth and Kinross Integration Joint Board of 4th of March for approval. Any comments on the accuracy of that record, please? If not, we'll now move to formally approve. May I have a proposer and a seconder, please?
Again, Bob, Councillor Duff, happy to propose.
Thank you, Councillor Duff. Seconder?
Happy to second. Oh, sorry.
Sorry, who was that again? I didn't.
Councillor Purvis.
Oh, thank you, Councillor Purvis. Thank you. Okay, and then item 3.3, minute of special meeting of the Perth and Kinross Integrated Joint Board of 7th of March for approval. Any comments on the accuracy of the minute before I move to approval? Okay, can I have a proposer and a seconder, please?
Happy to propose, Chair.
Thank you, Councillor McDade.
Happy to second, Bob.
Thank you, Beth Hamilton. Thank you. Okay, that now takes us on to the action points update. Can I ask Jackie to lead on this for us? You're on mute at the moment. Thank you.
Fine, thank you. Sorry about that. Thanks. So you'll see there in terms of the action log that we have work is continuing to ongoing in relation to reference 131, and discussions with the Director of Finance continue. Under item 132, I've provided a very brief update there in relation to the revision of the integration scheme, which will aim to clarify operational responsibility for inpatient mental health services sitting with NHS Tayside, and that strategic planning will become the responsibility of the integration joint boards, and it's likely that Perth and Kinross will be identified as the lead partner for that. So that really just gives a further clarification from the previous update on the 16th of February.
Okay, and 134?
And in terms of 134, I'm waiting a written update from Professor Stonebridge, and suggesting that that's provided to IJB members when that's received, to address the request for an update on oncology and radiotherapy services and signpost to relevant information that's in the public domain. So I'm happy to circulate that when that's received.
Thank you very much indeed. And 135 and 136, I note, are ongoing. Any comments about these action points before I move on? I have got Councillor Purvis and hold on a minute. I'll take Councillor Purvis first of all, please. Thank you.
Thank you, Chair, and thank you to the Interim Chief Officer for those updates. It was specifically in relation to the mental health actions and the new plan linked to that. There has obviously been some very concerning reports in the Courier recently about some very sad deaths in relation to Murray Royal. And I just wanted to ask, there were a number of, I think, outstanding actions that haven't been completed as far as I'm aware in relation to mental health, and specifically inpatient mental health. I think a while ago we did take a decision to have inpatient mental health as a standing item on the agenda. Now I know because of COVID and other things that stopped for a while, but I do think that that's something, particularly if we end up getting back strategic planning responsibility, or it's more clear through the integration scheme, that I think we do need to have sight of that on a regular basis. We were also expecting to have an update on the new director of inpatient mental health at NHS Tayside, and I would be keen to know, because given how important it is, whether any progress has been made in that regard. It's also just, I would make another point reiterating my desire, and I'm sure this is shared by other board members, to have updates as soon as possible on things like this. You know, the first I was reading about some of the details in these tragic incidents was in the Courier, and I think, you know, particularly if we retain responsibility for inpatient mental health at a strategic planning level, we do need to be made aware, and also of what actions are being taken to address these issues and try to avert such tragedies happening in future. So would be keen for an update on that. I know it was raised also at First Minister's questions, and the First Minister was going to get further information on it. So I would hope that we as a board, given our specific responsibilities in this area, would have more information. So I suppose that's a bit of a questions and a comment, but if perhaps we could have the first two specific points addressed as to whether we could have a standing item back again, and also on the Director of Mental Health, and then more broadly about updates on this area. Thank you.
Chief Officer.
Thank you, Councillor Purvis, for your questions. In terms of the revision to the integration scheme, there will be a period of consultation on the draft scheme, and I wonder whether it's an opportunity then for the IGB members to consider what would flow from that in terms of the detail and the detail of reporting, and an opportunity to discuss that at that point in time without actually setting out what that would look like at this meeting, if that would be a proposal we can take forward. My understanding in terms of the position in relation to Director of Mental Health, that the executive lead for that continues to be the Executive Director for Nursing, and she is retaining that responsibility at this point in time for mental health and learning disability. And in terms of updates, I think my first point clarified that I think we could consider what would the information that would be required to come to the IJB following on from the conclusion of the integration scheme.
Okay, Chair, could I just come very briefly?
I assumed you would, Colin. Thank you.
Thank you. No, that's helpful, and I think that's sensible in relation to the discussions around the integration scheme. I think if what the outcome of that is that we are still the lead authority in this area, that we would then need to, or in my view is we'd need to look to resume that as a standing item. I would be keen, and if other board members are happy and of the same opinion, if you could perhaps convey our desire to see that post recruited as soon as possible. I know it's clearly not for us to decide those operational arrangements, but if it's deemed necessary to have a post like that, and it is so important in the area of mental health, that to have interim arrangements for so long, I think is concerning to me as a board member, and would like to see some permanent arrangements brought in as soon as possible. And in relation to the updates, it would be useful if perhaps at a future meeting or by email on the specific issues that have been raised around Murray Royal, if perhaps we could have some more information and about what steps are being taken to try and prevent such tragedies happening in the future. Thank you.
Thank you. And if I might just pick up on your bit about reading things in the press, Callum, like you, I would also welcome having update on those rather than appearing out of the blue. And I think we need to look at communications about key events as they're happening between IJB meetings. So I appreciate that. I now move to Councillor Drysdale and then to Sandra Auld.
Thank you, Chair, and I'd just like to concur with a lot of what Councillor Purvis has said there, and I would absolutely support there being a standing item on mental health. It's such an important area, and we really need to keep this right at the forefront of our considerations going forward. My comment rather than question was in relation to 134 and the action point to contact Professor Stonebridge in regard to breast oncology and radiotherapy services, which are not within the remit of this board, but nevertheless there is this action point. Just to point out that my understanding certainly is that Professor Stonebridge is on the point of retiring very, very soon, and so it may well be that his successor or his deputy or whoever might be more appropriate to comment on that one going forward.
Thank you. Sandra Auld.
Thank you. It's just to follow up on Councillor Purvis's comment and question around communication. So I raised at the last but one meeting exactly almost this point around the finding ourselves in a situation where we read about things before there's any information or any communication from the IGB, and so I suppose and at that time my point was agreed with, and so this time I guess I would just like to ask for a little bit more detail about what is the current process where something major like this arises in the press. Is there a standing process that is current, that the IGB executive would be alerted to something and then that's filtered down, or and I guess if there isn't a process, could we look at putting a process in place rather than just taking this away and not progressing it?
Thank you for that question, and I'm going to go back to Jackie, please. Jackie, could you tell us what the current situation is with communications, because it does seem to be variable compared to other organisations, and I did wonder how we could improve communication, and I'd like your thoughts on that, please.
Yeah, I think it's a really important point to pick up on, and I'm not sure of what the current arrangements are in relation to those communications, or whether there's an existing protocol, and suggest that is a gap that would need to, that could quite easily be remedied, and happy to look at that for IGB members. But I think it's important to recognise that where we have a clinical and care governance risk, or where there are matters of this nature, the confidentiality that surrounds that, but also that there is an escalation process through clinical and care governance. Some of that will be locally within Perth and Kinross, and some will be NHS Tayside. So it's really just to give some reassurance to IGB members that there is a process for escalation in terms of clinical matters and clinical risks such as those that you've been describing this afternoon. But I think in terms of the communication of that and how that's disseminated, then I'm quite happy to pick up on a protocol and to see if that's something that we can agree as an IGB. Thanks.
Thanks very much. I know Councillor Drysdale is going to come, but I believe there was also a resourcing issue about this as well. But Councillor Drysdale, please.
Yeah, thanks. Right, so as a non-exec board member of NHS Tayside and colleagues who are in a similar position on this board and on this call, they will know that on an almost daily, if not totally daily basis, we receive an email on approaches to NHS Tayside media team with regard to issues about to be covered by the media, or that have been covered by the media during the course of a day, and very often that does relate to mental health issues. And similarly, Perth and Kinross Council obviously has a media team as well, and elected members are updated on these as appropriate. And I just think that the missing piece of the jigsaw here is a recognition by both parent bodies that if there is a health and social care related issue that is at the forefront of media attention for whatever reason, then I think it should be an automatic thing that these media teams convey that to IJB members, and I would hope that that could be an easy, quick fix.
It seems that Jackie seems to concur with that latter part. Jackie, do you want to just confirm that?
Yes, I think Councillor Drysdale makes a really important point that there are mechanisms in place. It's actually about pulling those together and from that drawing out relevant matters for the IJB. And if you're happy, I will undertake as an action from today to look at the existing protocols within the parent bodies, as you suggest, Councillor Drysdale, and seek to bring forward a remedy to the gap that seems to be there for IJB members. Thanks.
Okay, thank you. Jane Smith.
Thank you, Chair. I fully agree with Jackie and members around the need for a protocol. I would just, however, remind members of the governance arrangements and responsibilities of the IGB, which are different to the partner bodies, where the partner bodies are responsible on a day-to-day basis for operational risk and for managing that, and the IGB is not. It's responsible for strategic planning and therefore for strategic risk. And therein lies the challenge for coming up with a protocol that respects the different role of the IGB compared to the partner bodies. And I felt it was worth just making that differentiation.
Thank you very much indeed. Point well made, Jane. Councillor McDade.
Thank you, Chair. I just wanted to point out that the board did resolve to have a communications position a number of years ago. I can't recall whether it was under the immediate previous chief officer or the chief officer before that, but we did resolve. In fact, I think we've resolved twice on this matter that we would be informed of significant comms issues, as Councillor Drysdale has alluded to, at the same time as NHS Tayside Press was sending it to either the board of NHS Tayside or indeed council comms, and that was just supposed to happen. So the board has resolved to do this before. I appreciate the pressures that everyone is under, and perhaps the new interim chief officer can look out the position that was agreed, and that will save her from having to actually recreate the wheel here, because it should be somewhere, because we did agree it twice, so informally, but it was agreed, and I think it began to be actioned, but it's maybe just fallen out of the position. So
I think we get the drift, Councillor McDade. I think there is a general move to get more communication information, irrespective of the boundary lines that Jane has set out. Take Beth Hamilton, please.
Thank you, Chair. It was just really on Jane's point. I do appreciate the difference between operational and strategic responsibility, but I really think you can't do one in isolation of the other, and I think it's really imperative that the operational impact will impact on how we commission and plan our services. So I really do stress that I think we need to have a good communication strategy so we know what's happening on a day-to-day basis rather than catch up at a board meeting. Thank you.
Okay, thank you. And Sandra Auld.
Thank you, Chair. I now just wanted to come back on one of the other points that was raised regarding the communication to Professor or Dr. Stonebridge, just to highlight that whilst absolutely appreciating where the responsibility for these services lies, as in out with the IGB, but the diminution of the services has been a cause of great concern amongst members of the reference group. Such that I had the opportunity to ask a question directly to the Cabinet Secretary for Health regarding workforce planning associated with the services. So it was just to highlight part of his response, in which he indicated that there was funding available to augment, if funding was needed, to augment recruitment to some of these posts. And in relation to Councillor Drysdale's comment about Dr. Stonebridge just about to being retired, I suppose that also contributes to the wider issue around these services, whereby there aren't people to fill the posts that are creating the losses within the service. However, to wait until someone is in post for something that might take a considerable length of time, it would be helpful if there could be some sort of interim response from whoever has the interim responsibility for these services, so that the board is updated. As I say, leading back to the concerns that have been expressed by members of the public around this. Thank you.
Thank you for that, and I think we can note that request and ask for that to be included within the update, Jackie, if that's possible. Thank you. Hopefully we will know sometime soon about who the new appointment will be, as you indicated. Now, are there any further points on the action points before I move on, please? Okay. Are there any matters arising that are not agendaed on the meeting today? Okay, right, thank you. We'll now move to item 6, which is delivering on strategic objectives. Item 6.1, the Older People Strategic Delivery Plan. Jackie, could I ask you to lead in this before you bring your colleagues in?
Yes, thank you very much, Chair. The IJB is asked today to approve a new 3-year strategic delivery plan for older people. And this new plan, as you will see, takes account of the experience of working through the pandemic, and it aims to support older people to live healthy and active lives. It clearly sets out our ambitions and financial commitment to ensure older people and their carers are able to lead healthy, active, independent lives with choice and control over their care and support. The plan clearly sets out the direction of travel to deliver on prevention and early intervention, shifting the balance of care from hospital to community, and ensuring that people only stay in hospital for as long as they need to through a new approach called Home First. And I'll hand over to Evelyn Devine to say a little bit more about this report, because this is a piece of work that Evelyn's been leading on for a number of years. So hand over to you, Evelyn.
Thank you, Jackie, and thank you, Chair. Can everybody hear me okay? Because I'm having some IT problems, but is it all good? Yeah, okay. So thank you very much for allowing me to provide the IJB with an update in relation to the Older People Strategic Delivery Plan for 22-25. This is the second Older People's Delivery Plan that we have produced, and we've had some significant learning from the previous plan. So this plan is an updated version, and it is an updated version taking into consideration feedback from the IJB development sessions and the strategic planning development sessions, and engagement with EMT and IMT colleagues and other key stakeholders. It also takes into consideration guidance from Scottish Government in relation to new pathways of care and new policies that we need to adopt. The strategic delivery plan and its objectives link to our existing HSCP commissioning plan, and you will see as Jane presents the strategic financial plan that it links very clearly to the financial plan moving forward. So in relation to sort of the background and the issues, the plan takes into consideration both the increase in demographics, the impact of living with COVID, and more recently, I think we need to think about how we actually come out of COVID and learn to live and normalise where we're at with with providing services around older people in Perth and Kinross. So in relation to the impact of demographics, and I think you're all well versed in this because we've been through this already, we're projecting an over 75 increase in our population, and to date, since 2017, that's a 9.6% increase, and the growth is to move on in 2025 to about a 25.8% increase. Further to this, we're estimating 3,300 people living with dementia, and again an increase in relation to this in the next 15 years of about 50%. So you can see that this plan is not a linear process. We have to deal with also the impact of COVID as it currently is, and then the impact of COVID as we move out of the COVID viral pathways. So the impact of COVID that we're currently seeing is older people becoming more deconditioned. They are more complex, there's more comorbidities. And whilst in our last strategic delivery plan, we were able to focus very much on where we saw some of the long-term conditions increasing. For example, we invested in COPD and respiratory, and we also invested heavily in frailty. We still need to work this through in relation to the impact of COVID on long-term conditions. So what we're given a commitment to in this covering paper is the development of or the refresh of our joint needs assessment and the refresh of our locality profiles. Now, in relation to the joint needs assessment, work has already commenced on that, and it considers things like deprivation, rurality, issues around housing, issues around mental health, drugs and alcohol, and long-term conditions such as specific conditions such as diabetes, heart disease, etc. So we're giving a commitment that we will work with Scottish Government colleagues, our list colleagues, etc. to refresh. Now, this will not be a straightforward process because the quality outcomes framework we used to depend on around general practice no longer exists. So there's lots of different ways to gather information, including engaging with local people. So that is a process that we've begun, and we will give a commitment to in relation to this report. Further to that, we will be commencing our Older People's Strategy Board, and that will allow us to wrap around the strategic delivery plan with our Older People's Strategy, and also the Older People's Strategy, and an engagement plan around that. So in relation to sort of the key themes and proposals that are in the plan, I think most of you have had sight of this anyway, and I'll just highlight a few where the investment that we've had will make such a huge difference to how we move forward and embed resilience in our services moving forward. So our key themes in the plan remain early intervention. That is a key theme that has run through the previous strategic delivery plan and allows us to continue to invest in supporting physical activity, continuing to build strong partnerships with Live Active, Paths for All. It also allows us to invest in falls prevention in a more significant way than we've done before, and allows us to think about new models in relation to wellbeing teams in rural areas, which will support an outcome-focused approach. In relation to shifting the balance of care, and we have realigned these themes slightly based on the IJB comments. We continue to build our interface care, which was really about building resilience in and around our community teams, social work and social care teams, hospital at home, which is a new service for us, and increase in capacity, for example, around community alarm services. Again, in relation to urgent care, which is another new theme and a new pathway, and we will need to probably spend a little bit more time on this at some stage, but really looking to support the Scottish Government's review of urgent care, very much as an urgent care pathway that works in collaboration with acute services, and it's about providing the right care at the right time as close to somebody's home as possible and getting people on the right pathways to receive urgent care. In relation to the last key theme there, which is about optimising capacity and flow, we continue to invest in Home First and in sort of interim bed-based investments to provide support in relation to another Scottish Government directive, which is about discharge without delay. So this is a huge challenge for us currently. We do have quite significant delays in and around our hospital, and we are trying to normalise the COVID pathways by reducing the need for COVID wards and acute care, and allowing us to manage COVID in a different way in parent wards. So that is a new test of change that's happened this week, and we are currently working with that as we speak. So in relation to sort of the conclusion for that, I just wanted to just highlight just one more key theme that we've actually put in to the plan in relation to older people's mental health services and our commitment to transforming older people's mental health services in relation to, number one, understanding ageing and growth in relation to dementia prevalence, looking at social isolation and carers, looking at our bed-based models versus community and access to more community solutions. Some of this has fallen out of both the IJB sessions and also the strategic planning session, and we had already begun to try and look at this, but we obviously struggled with capacity to commence it to any great extent, so we need to look to move that forward over the next year. So in conclusion, in terms of the next 3 years, we continue, as Jackie says, to take a whole system approach to services that we provide for older people. We want to focus on early intervention and prevention. We need to avoid hospital admissions and provide care closer to home. But in order to do that, we need to look to the workforce. We need to develop new skills. We need to look at new roles. We need to look at new ways of providing care. So this all needs to work within the realms of the delivery plan. You will see at the end of the plan we have attached a high-level performance framework, which is very much based on the national performance indicators, but we're also working significantly at our lower level action plan and key performance indicators that will sit around that, including moving to understand more the patient experience and feedback and outcomes. And we have invested recently in care opinion, which will allow us to get some instant feedback in relation to teams and how they are providing care for people. So I don't think, Jackie, there's much more to say around that unless you have anything else to add. But I think we've covered most of what's in the delivery plan. Thank you.
Thank you very much indeed for that introduction. And I should say also we had an excellent development session recently on this. So I'm going to start taking questions now. And Beth Hamilton.
Thanks very much, Evelyn. I think it's really welcome to have this as part of a really good suite of strategic direction for the organisation, well, the IJB. It's well written, it's well done, and I don't know if Pat's joined us, but I know that Pat had a particular question around measurement and quality, etc. And I think you've addressed that. So hopefully that's something, as she's here, so she'll probably come in herself. But yeah, thanks for that. One of the questions I was going to ask, I was looking at, you were looking at consultation, you're looking at external, there's going to be a process of consultation with service users as it evolves. Just from a sort of governance point of view and perspective from us looking in, how will that be reported back and how will we be able to engage with the outcomes of that and the changes to the strategy over the next few years?
Yeah, what we're suggesting is that we would report back in 12 months' time, and in reporting back, we would report back on the engagement plan as well, Beth. So yeah, I think we can do both.
That's good. And the other comment about workforce and things, I've probably got questions linked to that in the next item about the home care. But yeah, I would agree with your comments around that. But thank you. I think this version's really welcome. Thanks.
And thank you very much indeed. I'd like to move to Sarah Dickey, then Sandra Auld, please.
Thank you, Chair, and thank you, Evelyn, for your comprehensive report, echoing Beth around how welcome setting out the whole of the phased approach to this strategy and how helpful that is. Couple of questions, please, if I may, and apologies due to planned leave, I missed the development session. In terms of the shifting the balance of care key actions on page 44, there's mention of implementing a hospital at home service, and I'm just thoughtful about language when trying to help our communities and citizens understand the different models that might be available for them, and also ensuring that we maximise on integrated team delivery. So just thoughtful that actually hospital at home in one regard is another example of how we deliver urgent acute type responses to the needs and clinical demands of the patient. So I suppose it's just a personal comment. I'm very thoughtful about hospital at home, because actually that's not what we want to create. We want to create something that's in someone's home that meets the needs back to the right person, right place, right time. My second question is in relation to the workforce and accepting and welcoming advanced nurse practitioners in the current programme, but noticing on page 46 reference to building on that model, and please may I ask that that is expanded to advanced practice models, so that it isn't just about nursing colleagues that we're thinking about, it's also allied healthcare professions such as paramedics or our full range of AHPs such as physio, etc. Thank you.
Evelyn?
Yeah, thanks, Sarah, for your comments there. In relation to hospital at home, this is a national programme. Sarah, it's obviously you'll know that's been rolled out across Scotland, and for us this is a test of change that we're currently doing. We are setting up a standalone team in relation to hospital at home, which will have medical staff, AHP staff, and nursing staff, and support staff within it. We are testing this initially. Our planning was to test this around the care homes in a more of a safe environment, with that 24/7 support. Yeah, we are planning to set it up as a separate team that will deal with some of those acute issues that could be dealt with at home. So that's the first thing to say. In relation to the AMPs, absolutely, totally agree, and we are looking to advanced practice both across AHPs and social work as well. So we need to be very mindful that it's not just about nursing staff, but we would be building on the sort of frameworks that we've put in and around advanced practice and how we move that forward. And I know the AHP modelling is still happening around advanced practice, so we need to take that into consideration.
Thank you, Chair. May I just come back?
Of course.
Thank you. Thanks very much, Evelyn. Just in terms of your response to my first comment and question, I am really thoughtful and recognise that you have a desire to pilot, and actually recognise that hospital at home, as you say, is a national title that's been given. However, I am really thoughtful around how the availability of workforce is one of our greatest challenge. It isn't funding, it isn't the models that are out there, it's actually the people to deliver those models. So I would be really keen to see the outcomes of the pilot, to be absolutely assured that there isn't workforce currently being aligned to things such as the links models, the other urgent care models that can't actually be blended and integrated in a different way. But obviously appreciate we need the pilot results to help inform that.
Yeah, thanks, Sarah.
Thanks very much indeed, Sarah. Sandra Auld.
Thank you very much, Chair, and thank you, Evelyn, for this report. I also understand the development session, which I wasn't able to attend, was really terrific. So I'm sorry that I missed that. I just wanted to go back to page 43, which lists some of the early intervention key actions. And one of the points mentions activity workers to support older people to be active while they're in hospital. I wanted to ask if those workers would be extended to people in care homes, or if the intention is just for in hospital. And a second question just around was around fuel poverty, and just how that is envisaged to be monitored in a rural situation, along with the next point, which is also food sharing networks, and again linked to rurality and the difficulties of implementing that. Thank you.
So in relation to your first question, we're testing the sort of activity worker model in some of our medicine for the elderly wards and POA psychiatric old age wards. And we already have similar types of approaches in and around some of the care homes in relation to Live Active Leisure, who are doing quite a lot of physical activity type roles within the care homes. So I think there would be learning from both models. Sandra, in relation to how that would look. So yeah, and we're also in and around care homes. We've been working on enablement training for care home staff. We have one of our AHPs who is training and education, has a training and education role, is really focusing in on that. So I think it's not maybe as much about the bodies, but it's about the training and development and the support. So I think there's learning from both of those types of models that we take into consideration. We're also bringing Paths for All into our dementia wards, for example. So we're trying to just cross-populate and look at what works best. So, I just think there'll be learning as we move forward. In relation to sort of fuel poverty and food sharing, I don't know if Kenny is on, because he might be able to give us a bit more of an update in relation to that. Or Jackie. There's Kenny.
Yes, I'm here. Thanks. Yeah, this is very much in conjunction with our wider community planning partnership partners. And in terms of scoping out, for example, fuel poverty, a lot of the initial scoping for that will come from housing colleagues. But obviously, we have lots of carers, etc., social work support going out to people in rural areas. So it's about us just being aware of any potential issues. For example, people receiving social work support get access to financial assessments and welfare benefits checks. So, it's just being aware of the issue of fuel poverty and then feeding it in through the community planning partnership arrangements to highlight that and signpost people in the right direction for any necessary supports. A lot of it's around maximising income, but there's also grants out there available for improving insulation, etc., in homes, depending on the tenure of the home. And the same goes for the food poverty as well. It's just making sure people on the front line are aware of the potential for food poverty, linking in with the wider community planning partnership, and again signposting or taking direct action to try and alleviate any issues that we come across. And like I say, particularly relevant in the rural areas where people maybe don't have as much immediate access to services and supports as maybe they do, for example, in the centre of the cities and the urban centres.
All right, thank you.
Thank you very much indeed. Donald McPherson.
Thank you, Chair, and thank you, Evelyn. My question's about the financials in the paper, so it might perhaps be one more for Jane than yourself, or perhaps between the two of you. But I notice in the paper, in year 3, there's an assumption of a £1 million contribution from NHS Tayside based on the success of this programme in shifting the balance of care. And my question was really just, well, firstly, has NHS Tayside committed to that? And secondly, are we clear what will be the measures of success that we need to be able to demonstrate to be able to achieve that £1 million contribution.
So I'm happy to bring in Jackie or Jane if they would like to respond to that.
Very happy to come in, Evelyn.
Thank you, Jane.
Thank you, Donald, for your question. Important to say, first of all, that when the budget paper comes forward, you will note that years 2 and years 3 are indicative at this point. The budget does absolutely include an assumption of £1 million at this point, but as I say, that's an indicative assumption. We have shared in full our assumptions with NHS Tayside colleagues, but in particular in relation to large hospital set side, we are just beginning a much wider discussion now around exactly what you've outlined, Donald, which is the baseline data, and over and above that, the performance measures which we will use to measure exactly the success of the older people strategic delivery plan, so that moving forward we can jointly with NHS Tayside monitor our success and seek to agree in year 3 what may not be a shift in resources from the bed base. It's very unlikely in the current demographic landscape that NHS Tayside would be in a position to reduce the bed base, but as part of their financial plan to look to perhaps other new monies that are available to them that can be used to transfer to the IGB as a mechanism of ensuring the shift in the balance and the large hospital set-aside arrangements, which are part of the integration scheme and sit at the heart of the strategic intent, can be delivered on without impacting on the ongoing bed base of unscheduled care. So it's a joint collective piece of work that we will do to set the baseline, to look at the measurement, for the ongoing monitoring, and then for NHS Tayside to look at how they might in year 3 seek to fund that if we're successful.
Okay, thanks very much, Jane. Thank you.
Thanks, Donald. And Maureen Summers, please.
Yes, I would like to just bring up under the delivery plan for old people the problem of the people with very challenging behaviour who are kind of stuck in hospital beds where they shouldn't be. They should be, you know, out in care homes with specialised staff to deal with them. And I was told a while ago that there was going to be 15 beds for this type of patient. But I just wondered what progress had been made, because we're getting asked at every carers voice meeting by 2 carers in particular who have both have husbands who are in Murray Royal and are just kind of stuck there, like, you know, because some of them have already been out into care homes and been rejected and put back to Murray Royal because they couldn't deal with them. And I just wondered what progress had been made on these beds so that I can go back and let them know at our next meeting. And also, you said that your delivery plan was tied into the financial plan, and I just wondered if that's been, you know, brought into the equation, like, you know, the extra cost that it might be for these patients, and that it is going to happen.
So Maureen, if I will bring in Zoe Robertson, if Zoe's on the call, and around the strategic commissioning of beds. But in relation to the financial plan, just to say, you'll note on the paper there's a phase 2 and a phase 3 within the paper, and phase 3 is still an area where we're looking to sort of allocate some resource, but phase 3 also has dementia services within it. So that's work that still needs to be done, and we will be taking that forward, but I'm happy to bring Zoe in.
Yeah, I think we maybe discussed this previously, but we have one care home who has a dedicated wing that they are attributing specifically to dementia, Maureen, and our mental health strategic lead and teams sitting under him are working with the staff team to ensure that the training is of an adequate level to work with people with a level of complexity and a variable level of complexity. So that wing has been refurbished and the staff training is in progress at the moment. So we're making positive strides towards fulfilling that, which is not to say that we don't need an additional resource if there are people who present with even more complexity that isn't able to cope with. But that's a piece of work that will be scoped out in and amongst a transformation programme of work in and around psychiatry of old age.
So once the staff have been trained, are there beds identified in certain homes where the staff will go to work?
It's one home and one dedicated wing. Maureen, I can't remember how many beds are in that, but roughly speaking, 12 beds within that wing specifically for that purpose.
There would be 15 beds overall, but I don't know whether they're going to distribute them between Perth City and rural areas, or how they're going to.
I think the ideal solution would be to have beds across localities along the same model as the interim bed modelling, so that people can stay in their communities, and it facilitates ease of access, certainly. Care home beds are not fully occupied and haven't recovered since the pandemic, and we do need to look at how beds within care homes are used, both within that capacity but also in assessment and recovery bed models. And as I say, that's part of the work that we're undertaking. And part of the actions within the delivery plan as to what's the best way to move forward with that, and which care homes are contextually best placed to do so, because some of them are really quite old and they're not really necessarily fit for that purpose. So we need to be able to scope out which homes are best placed to do so, and which homes have got the skill within their staff, and if they don't, how we need to support those staff. And that'll be supported with the enhanced care home model, which we have recruited to now, and there'll be one enhanced care home nurse for each locality who'll be dedicated to supporting that, alongside other associated professionals. So I suppose we're at the beginning of that journey, but cognizant of the need for that across localities, and at the moment specifically focused on this one ward at the moment.
So can you tell me what time scale this is going to take, and so that I can go back and give them an idea how long this is going to take? I mean, they've been bed blocking for 2 years already, so.
Yeah. I spoke with the care home group about 3 weeks ago, Maureen, and so I can go back to them and get an update and come back to you with that, because I don't know the specific deadline for that, but I believe it's imminent. So, but I can come back to you with that and make sure you've got that information for the group.
Well, if you could come back to me next week, because our next Carers Voice is on the 12th of April. So if I could go back to them with an answer for them.
I'll do my absolute best.
Thanks, Zoe. Actually, I think that information would be useful for the board as well, given the importance of that matter. Thank you. Thank you, Maureen. Councillor Drysdale.
Thank you. And my question, I've got 2 questions, and they're actually quite similar to Maureen's in a way. This whole subject area is of great personal interest to myself just now, and in terms of my own family, and so I'm experiencing for myself the difficulties and challenges in relation to caring for people with dementia, the various forms of dementia, etc. I just wanted to ask two questions in particular. One is on the finance, and one is on the support to the family of those suffering from dementia, and how we are supporting them as best we can. On the finances, I just wanted to be sure that I've got my figures right for Perth and Kinross. Am I right in thinking that the Scottish Government funding that is being delivered for older people's services in 22-23 is a total of around 7.6 million, and that is recurring? If you can confirm that for me. And secondly, just on the providing of assistance to the family of dementia sufferers. Clearly, it will often be the case that it's the husband or wife of the sufferer who is having to cope with this, and they will often be very elderly themselves and potentially frail. What considerations are given in these kind of scenarios, and what can be done to assist in keeping people at home or in a homely setting for as long as possible?
Councillor Drysdale, I think it's important to recognise that all of what you've seen, both in the financial framework and in the models of care that we're discussing, will all be there to support people and their families in relation to living with dementia, because these services are not just for people with physical health conditions, they're there for everybody. So if we need to respond urgently to somebody who has a delirium, for example, we would be able to do that as part of our locality integrated services. Our older people's mental health teams are integral to all of those pathways and services, and including that sort of early intervention and prevention around post-diagnostic support. Now we know we've lost some momentum in relation to that, and we need to pick that up in terms of waiting times to support people who need that sort of post-diagnostic support, and we're working hard to move that forward. But in relation to support of carers, I would be happy to bring in Kenny or Zoe to have that further conversation.
I was just going to add about. Oh, sorry, Kenny.
Sorry.
Oh, sorry, I was just going to add about the post-diagnostic support. We already work with Alzheimer's Scotland, and they have 3 post-diagnostic support workers, but we've just allocated that funding for them to recruit another 3 additional support workers. And Alzheimer's Scotland are coming to our EMT to discuss expanding their 5-pillar model to look at a community connections model, which will have outreach workers, or it proposes having outreach workers in each locality as well. So really cognizant of that growing demographic, increasing numbers of dementia, and how we need to expand what we do in the third sector, primarily to prevent people needing to use statutory services. But that model also works in and around the family and carers, not just the individual with dementia. So and the other development is that Alzheimer's Scotland are buying a building within the High Street in Perth, due to open in the summer, and establish their brain health hub, and are looking to base their post-diagnostic support workers there, and potentially outreach support workers should there be funding available to do so.
Okay.
Thank you for that. If I can just get clarity on the funding, the overall funding, the question about the overall funding and whether it's recurring.
Jane, do you want to come in there, Chair? Just to confirm, Eric, that almost the entirety of the Scottish Government funding received in the settlement for 22-23 is recurring, and that's set out in both the financial plan today and the older people's strategic delivery plan is all recurring, apart from non-recurring allocation for interim care beds, which continues, which is an annual allocation both this year and moving forward into next year. I think I'm right in saying that's £500,000. But as colleagues have said, we are looking at the phase 3. Not all of our recurring resources have been committed, and that phase 3 allocation that you'll see in the financial framework is being held to allow these further priorities to be worked through and for investment decisions to be taken in year 2 for priorities such as dementia, both community and bed-based provision. So that is there's recurring funding held to allow those future decisions to be taken.
Thank you, Jane.
Thank you, Councillor Drysdale. Jackie Pepper, please.
I think my comment goes back to a previous point that I think was raised by Sarah Dickey in terms of language, and it was to pick up on the communication around the older people's strategic plan, the direction of travel, and the kind of new service delivery models, and making sure that those are explained in a way that inspires confidence and understanding across the people who will be using those services. So I think you make a really good point there. And it was reflected in the development session that we had, Sarah, where the whole thing about language, that people could see themselves in this plan, and that this was constructed in a way for people to really understand it and have confidence in the direction of travel. So that's something that we continue to work on, Sarah. But I think as these new developments are coming to the fore, again, that theme of communication and understanding and shared understanding is really important. So thanks for raising it.
Well, thank you very much indeed. Lynn Blair, please, and then Patricia Kilpatrick.
Chair, my comments already been covered, so I'll not go back over it. Thanks very much.
Okay, thank you. I was hoping you would come in anyway. Thank you. And then Pat Kilpatrick.
Thank you, Chair. I mean, I really welcome the report. I do, and I think there's a lot of really good work in it. I'm still not happy with it, and I'll tell you why. If you go to the Scottish Public Health PHO website, it will tell you, as I quoted in the last meeting, the things that kill Scottish people, kill Scottish elderly people, are coronary heart disease, stroke, cancer, respiratory disease and diabetes. Now, these are not mentioned anywhere in this paper. We're not starting, Chair, from a position of these are the things that kill people, so how do we address them? And I'm very disappointed in that. We have had some discussion about poverty, although I don't think we're really tackling how we can deal with poverty, whether that's food poverty or fuel poverty. We've completely we've not discussed alcoholism, as I can't find it anywhere, or depression. And these are, two of the biggest things. There was a report done not last year, but the year before, about depression and loneliness and the impact that has on the elderly population. So I have to make the plea, Chair, that can we please start with the things that are affecting elderly people, rather than launch into what is a very good report, and it's very well written and it's got lots of great ideas in it, but it's starting from a premise of these are all the great things we're going to do, which is all very laudable, but we're not starting with these are the issues that face the elderly population in Perth and Kinross, and the report should then be based on that, not 101 great things that we're going to do. The other issue I think that's important to raise is one thing we don't mention anywhere is practice-linked workers, which I know you've invested a lot of money in. Practices have invested a lot of money in. The practice-linked workers could be key to your care of the elderly strategy. And the reason for that is it's not just about signposting people. You can signpost me, you can signpost Eric, and you can signpost Maureen or Sandra, any of us. We can signposting and people giving you advice as to who to contact. Elderly people, I'm not sure that signposting is the most effective way to get them to the right agency or the right part of their organisation. So I thought link workers might be a way of doing that. The other thing that's missing in the strategy is there is not much that addresses anticipatory care, which is the ability to work with people to prevent diseases. Another point is that public health are not mentioned much in here. Where is their involvement? And they have got great resources, great understanding, and great expertise in that. And they could help you out on if your strategy works, right? The type 2 late onset diabetes and the complications, including vascular disease, should go down. Stroke rates should go down. Coronary heart disease should go down, and cancer and respiratory disease should go down. These are things that public health can advise you on and how to manage that and how to measure that. I'm still not convinced about the measurement section 7. It feels like it's a bit of an apology at the end of the report. I'm sorry if that feels quite negative, and I don't mean to be negative. I'm trying to be constructive, but there are lots of things that we need to put in there, even things like the rate of admissions for over 65s, unscheduled care admission, and some of it you've got in. But it is probably the weakest part of your report. And given that you're looking for such significant change and such significant investment, I think it has to be the stand-up part of your report that says, here's how we will demonstrate what we have delivered. So those are my comments. I don't wish you to take them as negative, because they're not meant to be negative. They're meant to be constructive. But I do feel very strongly, Chair, that we have to start with the things that are killing elderly people, the things that reduce the life expectancy. If you look on the PHO report on the website, it will tell you that in affluent areas, you're likely to live 10 years longer than if you're in a less affluent area. Now, there'll be affluent areas in Perth and Kinross, and there'll be much less affluent areas. And what we should be doing with this report is addressing that 10-year life expectancy gap. And public health should be all over this. They should be your expert specialist partners in delivering this. And I hope that's taken as helpful and constructive. It's certainly how it's meant to be. Thank you, Chair.
Thank you, and I didn't take it to be negative. Evelyn.
Yeah, I mean, I'm going to bring Kenny in as well, actually. But I suppose, Pat, what we've committed to at the start of this this session really was to absolutely nail the strategic needs assessment, and that will be in conjunction with public health, with the list analysts, etc. We need to really refresh that, because we can't tackle everything. In the last strategic plan, we did tackle respiratory, but there's such a dichotomy now of comorbidities and sitting around quite a lot of these long-term conditions that we need to be really clear in terms of if people are dealing with 1, 2 or 3 long-term conditions, what does that look like? Then refresh that into the localities and then be able to really tackle some of these. So I think the plan is there. We just have to tackle that joint needs assessment with public health, just like we did in and around the mental health strategy. So we need to do that, and we have given a commitment to do that. I think some of the big killers in terms of older people is social isolation and lack of physical activity as well. So I believe we have kind of tackled that from an early intervention prevention, but I absolutely agree with you. We need to understand the demands out there, and that is a commitment that we've given to look at that. And then year on year, we need to see what we can tackle. Can't do everything at once, obviously, but what are the big hitters and what do we need to tackle? I think we have given a bit of a commitment in the document to that, but it has to wrap around the joint needs assessment with public health. But I'm happy to bring Kenny in as well.
Yeah, thanks, Evelyn. Just to confirm, on page 6, there is reference to cancer, heart disease, stroke, diabetes, and alcohol intake. And certainly, the whole gist of the early intervention is to try and work with people to encourage them to adopt healthy lifestyles, which obviously reduce the risk of developing a lot of these conditions. And just to clarify, in terms of link workers, we call them social prescribers. And we do have 6 social prescribers. I think that's about to increase to 9 social prescribers. And just to confirm, they do adopt a flexible approach. I mean, some people, it is fine, they can just signpost or link people into community-based services by giving them details of where to turn up, for example. But again, for people that maybe require that extra bit of support, they can actually work with them over a period of time, provide physical assistance, accompany them to various groups, activities, etc., until they're settled, and like I say, just provide that hands-on intensive support over a period of weeks, just to make sure people are actually able to access the supports rather than just giving them a phone number or a website.
Thank you very much indeed. And Councillor Duff, if you don't mind, I'm going to bring Zoe Robertson in at the request of the interim chief officer to answer some of this as well, if I may, and then I'll bring you in, Councillor Duff, if that's okay. Zoe.
Yeah, I suppose it would really just be reiterating what others have said. So this is a 3-year development plan, and we're in the process of already scoped out what an older people strategy would look like. And I suppose that's where I would anticipate the full depth of detail in relation to each of these conditions being explored more fully. And I would anticipate a performance framework attached to each of these specific areas of work as well, which is much more in depth and much more fulsome and much more able to evidence the work that we do undertake. And Kenny's right regarding the social prescribers. We've just taken on 3 new social prescribers and are working with GPs to align more closely the work of the social prescribers than has happened up until now. Unfortunately, during COVID, social prescribers were allocated to other work and to help cope with social work crisis situations. However, they're back on track now, and we've re-established a steering group and a very specific focus in and around the different client groups and the needs within that, mental health being very high priority.
Thank you very much indeed. And Councillor Duff.
Thank you, Chair. I welcome the plan before us today, which I find is a helpful summary of work past, present and future in this area, but I do also take on board some of Pat's constructive comments around some of the other areas for consideration as well. My question is on page 45 under phase 3, shifting the balance of care. And it talks there at the third bullet point about some further actions under consideration and about implementing a sustainable model for medicine for the elderly in community hospitals. And I was just wondering if anybody could tell me where this kind of work is at, and what are the key kind of issues that looking at and when we might see further proposals in this regard. Thank you.
I can come in on that, Councillor Duff. So we've been working for some time with our Medicine for the Elderly colleagues to not only have them inpatient facing, but having them community facing as well. So not just community hospitals, but care homes, etc. So we are aligning our geriatricians to each of the localities. So if a patient is admitted into PRI and they come from Crieff, the geriatrician from Crieff will follow that person back out again. So we are looking at doing that quite soon, actually, in terms of that ability. And we have been working and testing the geriatrician model within community hospitals quite successfully. And we've tested that in and around Blairgowrie Community Hospital and Crieff Community Hospital. And that's just allowed us to really have that MDT approach within a community hospital that we would have in an acute ward as well. So it's well underway, actually, and it has been well resourced already.
Okay, Councillor Duff seems content with that. Thank you very much indeed. I don't see any further questions in relation to this, and I think looking down, Jackie, do you want to say anything finally about this? I don't know if Jane wants to make another supplementary on this as well, but Jackie, do you want to bring this together? I'll bring this together, because then we'll go to recommendations.
No, thank you very much, and I think it's been really helpful to have all these questions explored and comment and receive the comments. And I wonder, given the importance of the performance measures and a performance framework that underpins this, picking up on Pat Kilpatrick's points, and I know that you've made this on a number of occasions, Pat, that bringing that back in 12 months' time is probably too late, and that it would be helpful to bring that back to the IJB in the next round of meetings, so that has greater visibility and opportunity for comment and scrutiny. And I'm sure we can do that in the next couple of meetings, and I see Pat would welcome that too. And I know you're moving on, Pat, into a new role, but I think it's probably too late to leave that for 12 months and to bring back a progress report, but bring back an outline of what the performance framework that would underpin this programme to either the next meeting or the meeting thereafter.
I've got Jane Smith, and then I have Sarah Dickey. Then I would like to move to recommendations. Thank you.
Thank you, Chair. Just to follow on Jackie's point and Pat's concern, members will be aware that there are performance frameworks that have been set out within the Learning Disabilities and Autism Strategic Delivery Plan also. And we're working on the same for the community mental health strategy. What that will do is significantly expand the performance framework and the performance report that will come regularly forward to the Audit and Performance Committee, where close scrutiny takes place of the performance in relation to our strategic ambitions set out in the plan. So I hope that's reassurance around quarterly reporting that will be done through the Audit and Performance Committee on the frameworks that have been agreed through our strategic plans over the last 3 months. I just wanted to make one further point in relation to the Older People Strategic Delivery Plan generally. I think it is fair to say that we focused on stabilising the system, expanding the capacity to cope with the current levels of demand, and accelerating investment in community services to prevent admission to hospital, because that's first of all what the system is requiring of us at the moment, and that is what the additional funding that we've received comes with, that being the priority that we've been asked by Scottish Government to focus on. So we've had to strike a balance in bringing forward the strategic delivery plan to ensure that it is meeting the immediate demands of a system, of the demographic growth that we know is going to come, and also meets the priorities that have been set out by the Scottish Government in terms of the additional investment that's been available to us. So I absolutely recognise the concern, totally support the work that needs done on the needs assessment, but we've had to strike a balance in terms of the plans that we've brought forward today in terms of stabilisation, increased demographic growth and Scottish Government priorities.
Okay then, thank you very much indeed. And I see that Sarah Dickey's given a thumbs up, so I guess she doesn't want to pursue any further comments or questions. I'd like to now move towards the recommendations, and the Integration Joint Board is recommended to accept that it approves the Older People Strategic Delivery Plan, notes progress to date from the delivery of the first Older People Strategic Delivery Plan 2019-22, and requests an update in 12 months' time. And I think we can probably add that part in about performance will come much earlier within that. Can we assume that within the understanding?
Agreed.
Okay. I'm assuming that the Older People Strategic Delivery Plan recommendations have been accepted. Thank you very much. I thought that was an excellent, very fulsome discussion, and we will now move on, but before I do, there was an earlier comment from Councillor McDade about action point 136, and just to say that will be actioned as quickly as possible, Councillor McDade. Thank you. The next one is 6.2, Care at Home Resiliency, and this is the Acting Head of Service. Could someone introduce this for me? Jackie, do you want to lead on this first before we introduce others?
Yes, thank you very much, Chair. I'll say a few words before handing over to Zoe Robertson, who's been leading in this, and just really to say that and acknowledge that the last 2 years have been undeniably very challenging for care at home services, and that to recognise that determination and persistence to provide care and support to people in their own homes during lockdown restrictions and managing everything that comes and has come with that, and acknowledge the specific challenges of delivering care at home and meeting needs within the geographical boundaries of Perth and Kinross and the rurality experienced. So Zoe will outline the review of care at home provision on the basis that the care at home provision was externalised 4 years ago, and that there's been a level of unmet need that has persisted. And the Care at Home Resiliency project was established to review that and rethink the model of delivery. And this report sets out a new and quite exciting approach which takes account of the experiences of the pandemic and seeks to build a more sustainable and flexible model of care at home, which is suited to the unique characteristics of Perth and Kinross. So I'll pass you over to Zoe to say a bit more about this report. Thank you.
Yeah, so as Jackie says, the purpose of the paper is to update on the outcome of the Care at Home Resilience project, and as outlined, the long-term unmet need within particularly our rural areas. It's important to highlight there's an increasing complexity of needs, certainly within care at home, and an increasing ageing demographic, as we know. We want to shift more specifically to an outcome-focused model of delivery, with the ultimate aim of empowering people to have greater control over their lives, have stronger connections in their community, and have access to the support they need within their local communities. So the Resilience project was broken down initially into 3 work streams. The first work stream was looking at an internal review, so what we do within statutory services. So we undertook to streamline basically internal processes. We created a single management structure within care at home. So although staff were still working in localities, it was centrally managed, and that's improved consistency of approach and has been particularly helpful for providers, and particularly helpful for those providers who work across multiple localities. There was a distinct effort made to reinforce choice and control within assessment activity, so not defaulting to traditional commissioned option 3 prescribed packages of care. We improved monitoring of waiting lists and thus our ability to performance monitor. In Workstream 2, it was devoted primarily to responding to COVID and the additional demand, and there was the creation of a temporary team, the switch team, and they picked up areas of care at home and reablement where we weren't able to respond to that either within our internal or external services. This increased our capacity temporarily and reduced demand and pressure on other areas of delivery. Workstream 2 looked at improving integration of core teams, specifically our heart and our discharge teams. And there was a focus on data analysis for us to better understand why some of the issues were arising that were arising. Workstream 3 was focused on long-term redesign. Community engagement activity was paramount to this, and we involved a wide range of stakeholders. There was an exploration of multiple models that worked across the UK. We invited guest speakers, learned lessons from other rural localities, or authorities, I should say, ultimately concluding that the wellbeing model approach to managing care at home would be best suited to meet our needs in our rural areas. I've talked about wellbeing models before, but they're self-managing teams that operate in local neighbourhoods. They tend to employ local people. They're values-led, focused on co-production, supporting people to make decisions about their life and support. They're committed to wellbeing, both of the people that they support, but also the members of the team. So not only do wellbeing teams work well for the individuals receiving the care, but we know from experiences of self-managed teams in other areas that this flexible approach derives an improved quality of work life and increased job satisfaction, which for us is particularly important and is vital to our ability to recruit and retain high quality staff. In addition to this, winter pressure funding that we received at the tail end of last year has been used, or part of that allocation has been used to improve paying conditions for our external care at home providers, to ensure a more equitable pay rate across care at home as a whole. And in addition, this funding has also been aligned to the new care at home model, the wellbeing team model. Both of these financial investments will improve capacity and meet current and future demographic pressures. We've already seen an increase in recruitment and calibre of applicants in response to that improvement in paying conditions. The 3 original work streams concluded, and the ongoing work was split into 3 working groups, which are called Strengthen the Foundations, which was talking about continuing to develop proactive and preventative care to ensure integrated support to people at home, supporting the workforce to thrive, so to nurture and strengthen the social care workforce so they feel valued, engaged and rewarded, and fit for the future, so to transform the way we plan and deliver social care support. And these working groups form the ongoing commitment to care at home development. Key areas of development, areas of focus from those working groups are the implementation of the wellbeing team, and flexible responses to care and support needs. An improved reputation of social care. So a digital marketing graduate has been recruited for 2 years solely focused on promoting the benefits of social care and working within it. Recruitment intention, so pathways into care have been developed, work placements for students, shadowing opportunities, sim flat, which I'm trying to think of the right word, but in essence simulates a patient journey from hospital to community so people can see what that journey would look like. A full utilisation of our self-directed support options, ensuring options are known and individuals are supported in accessing them. An investment in the young workforce, so developing the young workforce through secondary schools, through Perth College and youth services to promote careers and offer more work placements, through foundation apprenticeships and work experience. And employability, the implementation or the development of the implementation of a Get Into Care Academy will be launched to provide a partnership approach to be delivered by local training organisations delivering health and social care training. There'll be flexible training grants to support individuals to address other training needs and barriers, and individuals will be supported with job searches and employers supported to recruit via recruitment incentives. So in essence, the Health and Social Care Partnership will continue to work with partners to develop and design a flexible response, human rights, outcome-based approach to supporting people at home. The work of the team is ongoing and activity will be absorbed within business as usual, with all relevant officers and teams contributing as required. The most notable piece of work that we'll be taking forward within the next immediate coming months will be the wellbeing team, and if the posts are not advertised, they will be imminently for two teams of 10 within North and South locality where we are experiencing persistent unmet need. And so we ask the IGB that they note the content of the report and approve the developments set out.
Thank you very much indeed, Zoe. We are now open to questions on this, please. Are there any questions?
I put a question in the chat, Chair. I'm not sure if you can see it.
I'm afraid not. Sorry, Callum. If you just proceed, Callum. Okay, I'll take Callum first and then Beth.
Okay, sorry, I don't know whether the order might be different on our different machines, but apologies if I've come in first when I was second. Thank you very much for that report and the presentation. That's very interesting because I know that it's a problem that certainly in my own patch of Kinross we've had in certain parts of the ward, but also more generally in other parts of Perth and Kinross too. So it's good to see that we're looking to address that. I think you might have started answering the question that I was forming in my mind as you were going through and reading the paper towards the end of the presentation. But these wellbeing teams, they're employees of the council employees of the council on behalf of the Health and Social Care Partnership. They're not self-employed. If that's the first one, I've got a supplementary. Okay, that's correct. So the second part of my question is, and I know it was referenced like personal assistance and some of the other things in the report, but didn't go into in quite the same detail. One of the things that I've always been very impressed by, having met with the Health and Wellbeing Cooperative in Highland Perthshire, and we've looked at other models in other parts of Perth and Kinross, and it's good to see that you're sort of valuing the variety and community focused models and things like that. And I know that there was money put in the council budget as well to the partnership to support that. Is that something that's still being explored in parallel with these wellbeing teams?
Yes, it is. Yes, we've actually just support choices that we ended up using funding for, but specifically with that purpose in mind. So we've actually just received an evaluation on that, and I've asked for that to be presented at IMT and EMT so that they understand the real benefit of that piece of work that was undertaken by Support Choices. It means Support Choices is more about a sort of brokerage model and helping people and assisting them in terms of how to understand self-directed support and what option would look good for them, supporting them in how to access that, etc. But what they have actually ended up doing is supporting a lot of personal assistance alongside that. So yeah, I think that's really important, that this isn't a one a one-stop shop, if you like, that there has to be multiple approaches to doing this. And I think perhaps that's where we've maybe fallen down in the past, that we've kind of gone for one model and hoped that that would work, whereas now we're really broadening out, making sure that people make choice themselves about what option they do, that it's real informed choice, and that the third sector are involved in that decision making as well, that it's not just coming from a statutory perspective, that we're really embedding early intervention so that people might not actually need statutory services, and that a community resource or a volunteering resource might be sufficient for them. So really looking at it in that tiered way and tailoring the support around the person specific to their individual needs.
Great, thank you.
Thanks very much, Callum. Now Beth Hamilton, then Maureen Summers.
Yeah, thanks very much, Chair. I personally find this one of the most exciting things I've read in a long time. I genuinely think it's a huge opportunity for Perth and Kinross partnership to sort of take a huge leap forward. I think I mentioned in my last comments on the last topic about the employability issues, etc., and the workforce strategy. And I was particularly interested in raising the profile of social care and working with people from that perspective. Have we got a baseline to measure the success of some of the initiatives that you're taking, particularly the enhancing the reputation? I'm intrigued by the digital marketing graduate and the impact that that could have, because there is a stigma. I mean, there is a stigma around working in social care with older people, which just should not be there. So it's really a question around, are we clear that we've got our baseline so we can actually identify whether these measures, along with working with the young workforce, etc., are going to be successful in moving this into a more professional and positive experience for young people to go into?
Yeah, I mean, I'm very fortunate that Shona McLean, the service manager, maintains very good records in terms of employment and recruitment. So we know what the trends have been up until now, and that's how we've been able to monitor that improvement already. Say, for example, from that increase in pay and conditions. So I think I said at the strategic planning group that we've had 39 new applicants since we raised pay and conditions, which really went into force in January. So that's actually a really quite significant improvement for us. But not only that, and I think importantly is the calibre of people that are coming forward as well. So it's people who are interested in how we are articulating working in social care, and I think that's part of what we need to do is how we articulate that it's not about just delivering personal care. It's not about that time and task modelling. This is about working with people, understanding, knowing them, seeing the benefit of your interaction with them, having those relationships. So, you know, it's really about nurturing that type of relationship with people and aligning that to, say, for example, job descriptions like the social prescriber job descriptions, which are hugely popular when they're advertised because they talk about asset-based work, for example. Sure. So that we need to learn from that. What appeals, what makes people want to do this, and what is rewarding for them as individuals? Because if it's not rewarding, it is hard and challenging work. There is no doubt about it, and you have to acknowledge that. So there has to be something in that job experience that really, you know, people are getting something out of. And that's difficult when we've been going through 2 years of a pandemic and people are tired. So we really need to put some energy into this and a bit of zest.
Well, the energy comes through, and I'm looking forward to hearing how it progresses in the coming period. So good luck, and I think it's pretty exciting. Thank you.
Thank you.
Gosh, that's quite an accolade, actually. That's a strong one to live up to, Zoe, isn't it? Thank you. Thanks, Beth. And Maureen Summers, please.
Yes, I would just like to ask if there was any records kept of the amount of carers, I'm talking about unpaid carers like family members and people like that, who chose not to have carers come into the house during COVID and took on the extra caring themselves. And I just wondered if records were kept of how many chose to do that, and if there has been any approach to these unpaid carers whose own health is bound to be, you know, impacted on, you know, because of 2 years of extra caring, you know. So I just wondered if there'd been any approach made to these carers to ask them if they want help now that things are settling down. So.
Yeah, we do have records, Maureen, specifically of that. Some carers, as you say, elected themselves to not have anybody come into their home. They felt the risks were too high and they wanted to look after their loved ones themselves. So we know that, and we know that some people opted that we RAG scored everybody that received care at home to look at whether or not they needed the level of support and care that they had. Our quality monitoring officers have kept regular contact with those carers to make sure that they were well, and that happened throughout the pandemic, to make sure that people, well, the hope being that people were not declining in terms of their own mental health, etc. So I know that there were regular check-ins. I don't know when the most regular check-in has been on those carers specifically, though, Maureen.
Right, but there has been approaches made to these people just to ask them if they want extra help. Okay.
Okay, thank you, Maureen. Jackie Pepper.
Yes, thank you very much, Chair. I was just going to add, Zoe, to Maureen's question around the changes in terms of self-directed support and greater access to being able to employ family members, and so therefore the funding coming through that way. So yes, we've embraced that as well, Maureen. Thanks.
Okay, I don't seem to have any further questions on this. I'm just assuming there's no delay. Okay, in that case, can I move to recommendations then? And it's recommended that IJB note the content of the report and approve the developments set out in this report. Are you content with that recommendation?
Agreed.
Thank you very much indeed. I'm assuming that's the voice of everyone there on that one. Thank you very much indeed. Now I'd quickly like to go to 6.3, the verbal update on the strategic planning group, and then we'll take a break after that. Thank you very much indeed.
Sorry, that's me again. You'll probably be sick of hearing me. So the strategic planning group was held on the 22nd of March, and we had presentations on both the two papers that we've looked at today, the Care at Home Resilience Project and the Older People Strategic Delivery Plan. We took a slightly different approach to how we ran the strategic planning group and split people into 4 groups to try and ensure that it was a more interactive process for people. We split people into the 4 groups and asked them to identify strengths that they perceived within the papers, anything additional that they would like to see included in the approach articulated, if they were aware of other developments elsewhere in Scotland or the UK that they thought that we could learn from. And then this was shared and fed back into the larger group. There was a very broad mix of feedback, which moved beyond the remit of both papers, but would certainly influence the future content of an older people strategy. With regards to the Care at Home paper, there was a consensus that the wellbeing model of delivery is appropriate, that now is the time to do something different. Several members highlighted rising cost of living and implications for the social care workforce, which I know has been raised today as well, and our need to be cognisant of that. And one group discussed the concept of being an older person, and the range and diversity of services available should be fully encompassing and not just sort of stereotypical interventions. There was an agreement that one size does not fit all, that whole family approaches were really important, and that there should be support for a range of employment solutions, both paid and unpaid, and very strong support for a personalised approach and a move away from time and task. And in relation to the older people paper, there was an acknowledgement of the ongoing impact of COVID, of course, and the need to move forward, but still to take this into account. Wide support for the actions within the plan. There was a discussion around increasing use of technology-enabled care, and that it was important that this was a balanced or undertaken in a balanced and proportionate manner. We discussed the language used within our papers and how to make that more user-friendly. There was an ask for less complicated pathways and perhaps some additional work needed with regards to that. Strong support for community empowerment and older people being visible and valued within our communities, and ongoing engagement activity being crucial in moving forward with the plans and actions identified.
Thanks very much indeed. I think I've said before to the Interim Chief Officer, I very much like the sequencing of these meetings to enable us to have a written report would be my preference in future, and I know that she's going to take that point away. But I'm now happy to take any questions from your verbal update. Thank you, Zoe. I don't see any questions coming up unless it's just the speed of my chat box, but if there aren't any, then I would like then to thank very much Zoe for that update. And I'd now like, before we move to finance, to take a 10-minute break, and we'll see you shortly. Thank you very much.
it should then, right, can you hear this?
Okay then, I think we're now ready to resume. Hope you nice break. And we'll now move on to finance section and 7.1 3-year budget 2022 to 2025. Jane.
Thank you very much, Chair. I'm delighted to bring forward a 3-year budget for 22 to 25. Before starting, can I take the time to thank my finance team, my executive management team colleagues and their teams for the work that's gone in to develop the 3-year budget that's brought before us today in what has been a very complex landscape and very challenging circumstances. Can also thank IJB members who've participated in a number of development sessions and again have borne with the level of complexity that sits behind the budget today. The cornerstone of the 3-year budget is the strategic direction approved by the IJB for the next 3 years across our key programmes of care, and most recently in the last short while the Older People's Strategic Delivery Plan. Investment of £27 million is proposed in 22-23 alone across older people's services, community mental health services, learning disability and autism services, as well as significant investment in carer support and alcohol and drug services. For 22-23, a balanced position is set out and importantly fully aligned to the agreed budget contributions from both of our partners, Perth and Kinross Council and NHS Tayside. The achievement of balance is predicated on IJB approval today of the use of £1 million of unearmarked reserves, predominantly to bridge our prescribing overspend, whilst further work is done over the next 12 months to refresh our efficiency savings programme. For the first time since inception of the IJB, recurring financial balance is in our sights. This relies heavily on significant additional recurring funding from the Scottish Government, confirmed in the 22-23 National Budget Settlement. The pandemic has highlighted the essential role of health and social care partnerships in caring for our most vulnerable, and recognition of this by the Scottish Government in the financial settlement enables us to build the shape and scale of services that meet the ambitions of the Integration Joint Board. I'm delighted that the key strategic plans that underpin the budget include performance frameworks that will allow us to measure the success of this significant investment. And this is the first time in the history of the IJB that we've brought forward within our strategic plans performance measures that will allow us to consider the success and the impact of the investment that we're making. In previous discussions, we've talked about that they're not perfect, but they provide a strong basis for us to measure our success in a way that we've been unable to do before. Further work is required to consider how the future demand driving gaps in years 2 and years 3 of the plan can be offset. We can continue to consider potential efficiency savings, additional income, and where shifting the balance of care resources can be targeted, working with partners. As we've already discussed this morning, this afternoon, a key assumption in year 3 of the plan is a £1 million shifting the balance of care investment, predicated on our ability to demonstrate the success of our older people's strategic delivery plan in responding to increased demand and short length of stay, and in keeping people at home for longer. As I said earlier, we will need to work with NHS Tayside to evidence our success, and I would envisage extending our agreed performance framework for older people to include any additional measures agreed as part of those discussions. There are several risks set out in the report today that may impact on the financial position in the next 12 months, and we'll monitor those closely, reporting in the usual way to the IJB. In relation to ongoing COVID impact in 22-23, I'm pleased to note in the report confirmation of additional Scottish Government funding for ongoing COVID costs for 22-23, and therefore COVID does not present a financial risk. Discussions are progressing with NHS Tayside in relation to an appropriate level of financial support from the 3 Tayside IJBs to the inpatient mental health financial position in 22-23. The paper today sets out the key principles proposed by the 3 Chief Financial Officers in Tayside to underpin their further discussions with NHS Tayside. These principles have been shared with NHS Tayside but have not yet been agreed. The IJB is asked to endorse those proposed principles today. We will bring forward a full update on the 22-23 reserves position at the next meeting, alongside a review of the IJB reserve strategy. The delay in bringing these forward has been driven by ongoing discussions with the Scottish Government and across Scotland around use and transfer of COVID reserves. In conclusion, I'm delighted to bring forward the 22-23 budget for approval and the indicative budget for 23-24 and 24-25 for noting. I'm delighted to take questions either by myself or by colleagues across the executive management team. Thank you.
Okay, thank you very much indeed, Jen, and thanks to everyone who've enabled this document to come to us today. I'm going to start off with Councillor Drysdale.
Thanks, Chair, and as ever, Jane, thank you so much for your report. And that's now almost 5 years I've been involved in the IJB, and I think it's the first time that I've really looked at the finances and been more confident about the way forward in general. And thanks to you and your team for all their efforts in pulling this together, and briefing members in budget review groups and development sessions, etc. I just had one question, which is around the appendices, just so that I'm clear in my own mind. These are found on page 77 to I think 79. So the social care funding sets out Scottish Government income of 15,153,000 for social care, and then for health it shows Scottish Government income / uplift funding of 7,358 for health, so that comes to a total of around 22.5 million. But then when we look at Appendix 3, the figure, as I understand it, for Scottish Government funding is summarised at 19.5 rather than 22.5, and I'm just wondering, am I missing something? Is there something that I don't understand about? 15.5 plus 7.3 equals 22.5, but that equals 19.5.
Thank you, Eric, and it's a very good point. And off the top of my head, I am going to admit to not momentarily being able to connect the two figures. I'm going to ask Donna. It's quite a lot to ask of Donna about whether she's able to explain what is a material difference, or if not, we will need to come back very quickly to members to explain that. Donna, is that something you're able to explain at this point?
Yes, they had actually anticipated the question may come up. So the difference between the two figures, between Appendix 3 and the 19.5 million and the 22, as you rightly point out, with the two columns, is actually the uplift funding. So the uplift funding that comes via the NHS in order for us to uplift our pay and our non-pay budgets sits in addition to that 19.5 million that's laid out in Appendix 3.
Good stuff. Okay, thank you for that.
Thank you, Donna.
It's a tricky question that you thought there, Eric, because well done. Donald McPherson, please.
Thank you, Chair. And firstly, I think I'd like to echo Councillor Drysdale's comments about the achievement of the balanced budget. I don't quite have the same history as he does on this group, but I think it's an excellent outcome, and I think clearly a lot of thought and effort has gone into producing a well-structured budget. So thank you to you and to your team, Jane, for all the work that I'm sure has gone into this. I did, however, have an issue which you've already touched on in relation to Section 5, which is the inpatient mental health section, and the setting out of series of principles. I am conscious that as board members we wear different hats at different times, but I'm very clear that today I'm here as a member of this IGB, and my duty is to act in the interests of this IGB. But I do believe it's in our interests to maintain strong and effective and collaborative working relationships with both our partners. So just to be clear, I'm not here to speak for NHS Tayside in any way, but I am aware that they do have a different perspective on some of these issues. They don't view this as a large hospital set-aside matter, and they don't believe that they are or will continue to be responsible for operational overspends. Now, clearly, there are differences of opinion and discussions to be had, and I'm sure these continue. And I do think actually the approach that you're trying to adopt of agreeing principles is a good one, but I think it needs more work by all of the officers concerned to reach an agreed set of principles that are acceptable and can be accepted by all parties. And if this is proving difficult to achieve, then perhaps there's a role for mediation or some sort of device to try and bring what is undoubtedly an extremely difficult question to resolution. So certainly my preference would be that recommendation 1.5 was withdrawn, and that we ask the officers to continue to work together in partnership to reach a resolution that's acceptable to all parties. Thank you.
Okay, thank you very much, Donald. And I'm now going to go to Pat Kilpatrick.
Thank you, Chair. I just really want to support the comments that Donald has made, and I don't think it's appropriate to talk about a large hospital set-aside budget. I don't think that's where we are in mental health. I don't think that's what the mental health oversight group are considering. I don't even think that's ever been mentioned. So I think I agree with Donald, and I think Jane's done remarkably well to bring this budget in. But I think that we need to be very careful that we don't say things that are not factually correct. I don't believe Scottish Government have ever talked about a large hospital set aside. I also think that when it comes to accepting the costs and the clarification and the review of the integration schemes, I agree with Donald. I think that needs to be thoughtful and considered as to how we approach that. So I would not be able to sign up to these principles as they currently are, but I do agree that it's a good step forward, but I couldn't agree to sign off this as it currently stands. Thank you, Chair.
Okay, thank you. Maureen Summers, please.
Yes, I would like to say that I was at a meeting recently, and the figure of a £3 million overspend in inpatient mental health services was mentioned. I just wondered, how that's going to be addressed, because obviously, That 3 million is 3 million less that's been spent on the community mental health services, and I just wondered, you know, how that actually has increased year on year for the last 3 years. It's now 3 million overspent, and I just wondered how that's been written into the budget.
Jane, I'm going to bring you in here. Thank you, Maureen.
Thank you, Chair. Can I just answer Maureen's question first of all, and then come back perhaps to respond to Pat and Donald's comments? Maureen, you're absolutely right. The forecast overspend on inpatient mental health for next year is considered to be of that figure. And the discussions that we're having with NHS Tayside colleagues is about how we, as 3 IGBs across Tayside, can support NHS Tayside in addressing that overspend, regardless of individual principles. The 3 CFOs are very keen to do all that they can to support NHS Tayside in an appropriate way, given the governance arrangements that we're working within. So you're right, Maureen, and that's what these principles are here to address, to find a way to support NHS Tayside with that significant overspend. Coming back to the points that Donald and Pat have made, I sit here before you today as your Chief Financial Officer, as the person who is here to give you advice on financial matters. The financial advice that's implicit in the paper today is the professional opinion, not just of myself, but of 3 Chief Financial Officers across Tayside in relation to the type of arrangement that's in place, the arrangement that has been in place as part of the annual accounts process last year, signed off by external audit, and that will be in place for 21-22. That said, I fully recognise the need for constructive and collaborative discussions with NHS Tayside colleagues. However, this has been difficult to achieve. A joint conclusion on this has been difficult to come to, I do need to the IG members to recognise this. But perhaps I need to say no more than I bring to you today my own professional, opinion on the way in which the IJBs need to enter those further discussions with Tayside colleagues, in which what we're trying to do at the end of the day is provide support to a balanced position on inpatient mental health to allow the most important discussions to commence, which is about an affordable financial framework for the longer term. And that is what we need to quickly move on to discussing.
Okay, thank you. Do I have any more questions at this time? I'm not seeing anything. That could be a delay though. Right, thank you. Callum Purvis and then Beth Hamilton.
Okay, it's just a comment. I thought I would wait until there weren't any more questions. Just a number of points I'd like to make as chair of the Budget Review Group, if I may, and just to reiterate those thanks from others to Jane, to Donna and her team for all of the efforts that they have put into pulling this budget together. I know that it has been challenging, to say the least, but I think that reflecting on the points that Councillor Drysdale made, it's quite optimistic where we're at. I'm very pleased that we have managed to put together a 3-year budget, including those indicative budgets in years 2 and 3, given that some other public bodies are perhaps struggling with that. So, but I'll leave it at that. That's very positive, and also what that might mean for the future in terms of being able to look at forward planning for things like large hospital set aside, and that the shifting the balance of care and releasing some of those funds, because that's where we're all trying to get to, investing more in community-based services so that we don't need to have as many people in hospital or in acute settings, and perhaps it's not just restricted to this IGB. It's been a problem all across Scotland that maybe we haven't been able to release as much of that funding as we would like. That's not necessarily just our fault. That requires the agreement of the partners as well, but it's very promising that that's something that is on the horizon. I'm also very pleased by the inclusion of the strategic delivery plans and getting better at linking the outcomes that we're trying to achieve with the financial plans, and also linking that with the performance indicators as well, and looking at those through the Audit and Performance Committee. So I think this budget is certainly the best one that I've seen. You know, there's been progressive improvements each year, which I think is really positive. And also, you know, it's welcome to see the additional funding and the uplift from Perth and Kinross Council, you know, mostly as a result of that Scottish Government funding. And I hope that the NHS Tayside are able to agree to pass on that money in full as well. Just on the comments that Pat and Donald have made, I think it's no secret that my preference was not that the arrangements were transferred back to NHS Tayside. I think that if we retain responsibility, we should have retained the financial responsibility, and I have raised my concerns in relation to the chief officer role, that if the chief officer is going to be responsible for certain things but not holding the budget, and that does raise some questions. But unfortunately, you know, the reality of the situation is we are where we are at the moment, and that's not going to change. Perhaps the integration scheme or the new appointment might alter those, but that's not the case at the moment. What I was going to ask for Chair is if we could perhaps just have a short recess, and perhaps once the initial comments have finished, and just so I can reflect further on those points that have been made, if that's all right, as I'm sure others might want to do.
I'm happy to do that. I just wanted to, I want to bring in Beth Hamilton, and then I'd like to ask Jane a question, and then we'll take that short break, okay? Beth Hamilton, please.
Yeah, thank you very much. Jane, I think I mentioned at the budget review meeting that I was happy with the 3-year approach. I think that's really helpful to lay out the future, but I did express concern, I think at that time, about the assumption of the extra £1 million from the large hospital set aside. So that you know is where I was coming from. What I'm a bit nervous about is the inpatient mental health. I think that's a separate issue. I mean, I feel about the older people and the strategic direction and making assumptions for that is one thing, but I think it's pretty important that there is a general understanding around this board around what is exactly the position within patient mental health. And I get what you're saying. I genuinely think it's really positive that there's some discussions going around 3 IGBs, because this impacts 3 IGBs. But I would really feel in a difficult position to agree principles which I don't fully understand, and I haven't got the perspective of everybody. So I think that inpatient mental health section is something that I would like to look at separately, and maybe have a separate budget or finance meeting with representatives from health and council, and you know, the IGB, the partnership finance staff. So that's my position.
Okay, thank you very much indeed. Jane, I guess I think the comments have been very positive about the paper overall, and clearly there have been issues raised about Section 5 on inpatient mental health. I mean, very clearly, this I'm presuming would be your negotiating position. Would that be correct language to say? Is that's essentially what you're asking us to endorse? And so I think that's one of the questions. And the other question is, to your knowledge, do you know if the other 2 IJBs have similarly endorsed these principles at board level?
So I suppose 3 things to say, Bob. First of all, you describe a negotiating position, and you know, I suppose in hard and fast terms that is, you know, the reality. But you know, we are desperately trying to come to consensus on this, and having regular meetings, to discuss and try to move it forward. But it would be very helpful to have an agreed IGB position. 2 things further then. First of all, the other IGBs have not had the opportunity, the other CFOs have not had the opportunity to bring forward the principles in the way that I have done today. What I would recognise, you know, in listening to board members, as whilst there has been the opportunity to have budget review group meetings and development sessions in relation to large parts of the paper today, this actually is one area where we've not had that opportunity to discuss. And I have to recognise that here today when listening to the concerns of board members that we have not had the opportunity to get into some of the detail that sits behind my recommendations, and perhaps that might be a useful next step, is to have a dedicated session in relation to this that you know, makes members with their, you know, very much with their IJB hats on, more comfortable or otherwise with the recommendations that are made today. So yeah, I hear the concerns, and perhaps there is another way forward.
Okay, I'm going to take a break just now. Callum, how much time do you need for this break? And
just 5 minutes should be fine, if that's all right.
That would be fine. Okay, and then I'll come back and I'll pick up Ian McCartney's question. Okay, thank you. If we just take a break for 5 minutes, please. Okay, I'm ready to start again, and Callum's still to get back to me, but I'm going to ask Ian since he asked the question. And Ian, do you want to? You're on mute at the moment.
Okay, thanks, Bob. It was hopefully a quite simple question in that, is there a process and a procedure laid down or agreed between the two parties in the event of no agreement as to each's view on how the budget's constructed? The reason I asked this, in the past I've had to deal with a situation almost exactly like this, which ended up in the Workforce Acute Trust going on strike in protest. And the disagreement was about the budget, and the trust went ahead and made public its budget, which was more than 3 million over what their current budget at the time was, and there was no process available at that time to do a different way of dealing with it than encouraging the unions to strike. So we're just wondering what is the case.
Jane, can you take up that point, and then I'm going to bring in Callum.
Of course, yes, thanks. I assume you mean specifically in relation to this issue that we've just been discussing around inpatient mental health. Yes. So this is a really complex issue and in many ways uncharted territory for all of us around the kind of table trying to find compromise. And I'm really hopeful that through the further discussion we will reach a position that very much puts at the heart of it the need to move forward, reach a compromise position and move on to look at the kind of wider financial framework sustainability issues. So there is no, agreed negotiating process, if you like. However, we hit these difficult issues all the time, Ian, and we sit round the table, we discuss them, and eventually we will come to a compromise. And I have to say, I would be very, very, sad if the budget discussion today was overly dominated by an issue such as this, where we've still got a way to go in the discussions, and where the offer and suggestion of a development session with IGB members to discuss this in more detail is what I would now propose.
Right.
Yeah. Okay. You should have been a Sorry. Yes, you should have been a politician with that answer.
I think Scott Hendry said something about politics earlier on today, so right. I don't think.
I'm not mentioning any particular politics.
Okay, Jane, thank you for that, and we may come back to that when we come to recommendations. Callum, can you assist us here?
Thank you, Chair. It was just to build on those points that have been made and reflect some of the concerns that have been articulated by board members. Clearly, members, not all members are comfortable with the recommendation as stands at the moment. But I do think we need to recognise, this has been a long-standing issue, and there have been long discussions between the chief financial officers and the relevant counterparts in NHS Tayside. So perhaps as an alternative, I know there's not agreement to agree those principles today, but I do think we should acknowledge that that's the professional advice from our Chief Financial Officer for the Integration Joint Board. So perhaps instead at 1.5, if members are content, something like that, we note the professional advice from the Chief Financial Officer as set out in the relevant section of the report, and that we agree to have a development session for the Integration Joint Board to form its own view on this issue. As soon as practically possible, if that would be acceptable to members.
That sounds like a good compromise approach to me. Are there any comments specifically on that matter? Okay. I minded Jane and to just go to the recommendations now, and then we deal with the 1.5 with the form of words that's appropriate for the board, that as around what yourself and Callum have suggested as a way forward. And and I see that, hang on a minute, I see that Councillor McDade is happy to second that proposal. Donald, do you want to say anything before I move to looking at the recommendations?
Yeah, sorry, I was a little slow on my chat typing, but yes, I think I would be more comfortable with the approach that's proposed here, and I think gives us a better roadmap to reaching a resolution.
Thank you, I appreciate that. Well, in that case, thank you, Jane, and I'm now going to move to the recommendations, and I'd like to take each one in turn so that we can deal with the last one separately, but I just want to be clear that we're all in the same place. It does take me a while to get up there. Okay, Maureen, I'm going to go to recommendations. Is this connected to recommendations?
You're muted, Maureen.
You're on mute, Maureen.
No, I was looking through the paper again during that last break we had, and in particular to the inpatient service and the actual columns of figures, and I couldn't see any reference at all to the £3 million deficit for mental health. So I wondered how that's going to be incorporated into the report. I mean, it's just not mentioned as far as I can see. I may be missing it, but I couldn't see any reference to that £3 million deficit. No.
I think we're primarily looking at over a given period of time. Jane, do you want to just briefly answer that before I move on to recommendations?
Yes, Maureen, you pick up an important point. The operational overspend associated with inpatient mental health services sits within the budget and the ongoing position of NHS Tayside. That was the case in 2021. It's the case for 21-22, and what my advice in the report today is that is the assumption that is what will continue to be the case moving forward. So it's not in our budget. It's not in our monitoring position. That's in line with the arrangement as we see it as professional CFOs, and that's the heart of the ongoing discussion with NHS Tayside colleagues. So you're absolutely right, it's not there, and that's because at the moment we don't hold operational management responsibility for that budget.
Thank you, Jane. I'm now going to move to the recommendations, and I'll deal with each one in turn, if I may, so that these can be signed off separately, and then we'll come to 1.5. So does the IJB approve 1.1, the revenue budget for 2022-23?
Approved.
Agreed.
Thank you. 1.2 notes the indicative budgets for 2023-24 and 2024-25.
Noted.
Agreed. Noted.
Thank you.
Agreed.
1.3 approves the use of unearmarked reserves for 2022-23.
Agreed.
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 Thank you. And 1.4 requests that the interim chief officer issues the necessary directions to NHS Tayside and Perth and Kinross Council.
Agreed.
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 Okay, thank you. Now to 1.5. Can I have a form of words that would enshrine the comments that both Jane and Callum have said, and then we can move to approve that or otherwise? Callum.
Happy to try with that. So I think what I would suggest is that note the professional advice from the Chief Financial Officer of the Perth and Kinross Integration Joint Board as set out in the report on the issue of inpatient mental health financial position, and agrees to have a development session to form the IJB's own position on this issue as soon as practicably possible.
Thank you. That's a pretty clear one to me. Thank you so much indeed, Callum. Does the board support that recommendation to replace 1.5?
Agreed.
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 Thank you very much indeed. I think that's a very good outcome, and it enables us time to consider this issue much further, and we'll look to a suitable timescale to be having that. And thank you very much indeed, Callum, for putting that together. And Jane, also I want to thank you and your team. I appreciate just how difficult the exercise has been. I think you used the word challenging. It's been super challenging to even get a balanced budget. So I'm absolutely delighted that we've got to this stage, and you'll get my full support in moving this forward into the next stage. Okay, thank you very much indeed. That now takes us to governance, section 8, and 8.1, a membership update, a verbal update by Clark to the board.
Thank you, Chair. I'll be brief with things to update members on. Just to remind members, I think we'd noted this before, but Pat Kilpatrick will leave the IGB as a voting member from the 1st of April, and a replacement will be sought from the Board of NHS Tayside as soon as possible. In relation to the other voting member position from NHS Tayside, I can confirm that Donald McPherson has been appointed to the vacant position of voting member for NHS Tayside. Thank you.
Thank you. Thank you very much indeed, and I'll have a chance to say thanks to Pat at the end as well, and I'll probably have some other goodbyes to say as well, and thank yous. Thank you very much indeed for that. And I'm now looking to 8.2, membership and roles on integration joint boards. You will have seen a paper, or a brief paper, circulated by Ian McCartney on behalf of the public partners after the main papers were issued. And what I wanted to have was to have an open discussion on this, because I think it's a very important matter. And it was one I've had to reflect on quite a lot on the discussions, particularly that took place at the recent IJB meetings, where we were considering the chief officer recruitment process. And we discussed this matter at the pre-agenda meeting, and both myself and the vice chair agreed that it would be helpful to have a general discussion on this at this meeting, to seek the board members' views on membership in general. And I wanted to perhaps lead a general discussion as well on that. Now, this is a pretty open one, but when I was considering where I wanted to start with it, I'm happy to leave the paper that was sent by Ian and his colleagues as there, but what had come up for me was about a number of things, really. One is about the role of stakeholders as well as public partners as well, and how we can build on that moving forward, because clearly the issue of seeking more empowerment has been an issue. I also wanted to look at the effectiveness of that work with the strategic coordinating group, where it's the one area where we could definitely influence agendas on the IJB with what the outcomes are from the strategic coordinating group. I was also very struck by some of the things that were in some of the paperwork today, and and particularly I was picking up some of the work on the strengthening our alliances with community partners and third and independent sectors to improve lives and opportunity through a stronger focus. And we were then looking in terms of the older people strategy on prevention, early intervention and targeted actions on the wider determinants of health and well-being. And I was very struck by that as the automatic genuine turf that I believe particularly carer reps and service user reps would have an immense focus on, and indeed our other partners with the third sector. And also at the care home resilience paper as well, we were talking about continuing to work with partners to develop and design flexible, responsive, human rights outcome-based approaches. And when I thought about that a bit more, I was then looking at some of the issues that we know are really important that help to support people. And some of them, Mrs. Kilpatrick mentioned earlier today about public health priorities, but there are some of the other ones as well, which I think are endemic and lead to enormous what I would call health and social deprivation, which we know lie at the root of many of the issues that we have to deal with, and often can lead to some of the illnesses and conditions that we have to address further down the line. So there's something about our equality and diversity proofing that seems quite important to me, thinking forward and how we go about improving that. I think there are clear issues about health and social inequalities, but also this issue around about human rights as well, because again, what consistently carers and service user reps are talking about, and I think Maureen alluded to this today when she was referring to people who were staying in care homes in hospital for inordinately long times before they receive the correct kind of service that they need. And this is not an uncommon problem in Scotland. But I felt there were some issues there that were linked to the issues that had been asked in the paper. As far as I know about the legislation, no one can say with any clarity on this, and I have spoken to colleagues through the National Care Service group who are overseeing this, is that we will likely have some form of bill by June, but that's as much as I know, and that's all that anyone's prepared to divulge at this moment in time. So I kind of wanted to put down some of these markers as part of a general conversation, and I just welcome your comments on that.
You want?
Ian.
Yeah, thanks. Thanks for also circulating the note from the four non-voting members of the group. We're actually in a time where across the whole of the health and social care sectors, there's a great deal of discussion about how taking forward not only the issues about procurement and the infrastructure we have for health and social care and the changes that will undoubtedly come out of the proposed legislation after we receive a draft bill. And most of the changes have taken place in the last 20 years or so to better the relationships between the organisations in health and social care, patients and users' rights and carers' rights, have actually come at a time of new legislation being proposed. And we're in that situation. And being in that situation, I think it's important for all of us to take an opportunity to see if we can come forward with some proposals that can be considered as part of the legislative activity in the Scottish Parliament to ensure, hopefully to ensure what comes out represents a position that would ensure that going forward IGBs in Scotland, or whatever else they're going to be called, have a set of rights and responsibilities in relation to community groups, health charitable bodies, and of course representatives of carers and service users. From my perspective, I would like to see us maybe create a small time-limited group to go and look at what's available now, what works a bit but could be better, and what we need to do going forward with a common approach to engagement with our citizens. And this has always been critically important, and the powers that be have never always got it quite right, whoever they may be. But one thing is certain, that the delivery of changes in social care and the integration of primary and secondary services can be best done at a local level with engagement with local communities, and through the local communities, their elected representatives who are represented around this table, and also those who represent, as I say, carers and users of services working in conjunction with councillors. I see this about bringing about, not the word revolution, they're a bit strong, but bringing about a way of working between elected members and members who are not elected in the same way, but who have got skills and knowledge and want to put that them forward in the discussions, because none of us around this body want anything other than the best that we can possibly provide in terms of staff, service users, and of course the well put on carers who seem to, despite everything that's thrown at them, continue to do a fantastic job. And so I'm pleased that you've agreed to have a discussion about this. It was my intention to set down in concrete a proposal, but I would like to see us agreed in principle that we'd like to see both here and in Scotland support for a better way of engaging in consulting and delivering services, and what we could bring to the party with that in terms of when the Parliament discusses things at Perth and Kinross, IGBs at the forefront. People like to see what we're doing, how we're doing it, and working together in a partnership, which I think is very important that we do that. And so I'm hoping that during the rest of this discussion, people can put up ideas, but certainly I'd hope at the end of this discussion, we would get a group together, which I think you've done in the past for other issues, and to come forward with ideas and proposals to be considered submitting to the Scottish Government and its legislative programme. Thanks, Bob.
Thank you, Ian. I'm grateful for that. I'm going to take Councillor McDade and then Maureen Summers.
Thank you, Chair. I've got a few points, and I know I often sound like the board's historian here by referencing past decisions. I'm afraid is the fact of having been around for 5 years now at this point, that I have been through this discussion a few times now, so you'll forgive me, and possibly Councillor Drysdale for repetition of ourselves. The board has previously had these discussions on a number of occasions, and on all occasions, in my recollection anyway, we have agreed that the powers and the treatment of the service user board members and the carer board members, the public partner board members in general, needed to be recognised in a number of ways, including by arguing for voting rights. And I think at some point the chair of the board, I can't remember which of, I think the 5 or 6 chairs of the board that have been in my time, wrote to the then relevant minister, whichever relevant minister it was at the time, to say that that was the position of the IJB. I actually think we should be going further, and I have raised this before as well. I think that the level of work that goes in for being a member of the IJB, which is not inconsiderable, and those of us who are council nominees and those of us who are NHS Tayside board nominees appreciate how much of an additional workload this is on top of our other respective duties. I do feel that public partners, who are the only people around the table who are not financially recognised, should also receive some financial remuneration for recognition of their work that they do on behalf of the public. And I feel quite strongly about that, because I think that they are the only people who are being asked to do it for free, and that they should be recognised properly. But that again is another matter. I think that is a matter that actually the board might be able to do something about. I don't think we require legislation. I've asked this question before. The voting rights matter, we do require a change in, and I have looked for various loopholes in this in the past about whether the council could nominate the public partner reps as a way of getting around those provisions, and I have been assured several times that it is not possible and it requires a change in the primary legislation. And therefore, I think that we should continue to hold the position the board has held for the 5 years I've been on it, which is that public partners should be recognised and appreciated by given equal rights, voting rights, and that the chair and vice chair should continue to advocate the board's agreed position on that matter. I think that we should also, as I say, be looking to provide some sort of compensation to the public partners for the huge amount of effort they put in, and they do quite a lot. And they have never asked for money, I would add. You know, this is never something they've asked for, but it's something I strongly believe that we should be seeking to support them with, because it is a significant additional commitment by them on behalf of the public. And I don't think that we should just be relying on their good nature, and they are here because they passionately believe in it. So I'm very pleased, Chair, that you've brought this forward for a discussion at the board, and I hope that the board comes out of this with a stronger resolution. I don't think we need another short life working group. I've been on several of them to discuss this issue. Personally, I don't think we need another one. I think we are all fairly on the same page, unless there's some galloping change of position from board members. I think what we just need to do is resolve to make the case stronger to government as they are looking to make these changes. And I know that this discussion has been held elsewhere across the country as well, and that there is quite a strong commitment across the country to give public partners the vote and the sort of the strength and rights that they deserve.
Thanks, Callum. You have the benefit of longevity there to say about previous working groups on this. I'd certainly like to see what that was as part of this inquiry, as it were. I'm going to take Maureen Summers and then Sandra Auld.
Yes, I like to think of you know, the unpaid carer reps and the public partner reps as experts through experience. I myself have been an unpaid carer for over 27 years now, and that just gets thrust on you, you know, and you have to learn to deal with it, like, you know. And that is really what prompted me to get involved in things. So I have been involved at various stages with NHS Tayside over the last 20 years anyway, like, you know. I did sit in the public gallery during the CHP meetings, which were the predecessor of the IJB, and then it was decided that we could have, you know, a carer rep sitting actually around the table. So it was great to do that. That must have been about 8-9 years ago now. And then when the IJB came in, we had to go through an election process ourselves. We just didn't land here. We had to be, voted in by other carers, and and hopefully we represent them as well as we can and feedback, any information, bring their, issues to this meeting and other high-profile meetings such as the Strategic Planning Group. And we feedback, at our monthly meetings to any queries that have been raised by our carers. So it is significantly time consuming, but it's something, as Callum said, we are very passionate about what we do. When we get the papers, and I go through everything, not just a bit that's concerning me, which I suspect maybe some professionals do, I'll need to ask questions about this here because this is my expertise. But we go through all the papers, myself and the other carer rep, and Sandra and Ian have a similar process that they go through to discuss the papers prior to coming to the meeting. So it's not something that we take lightly at all. We're very committed to it. And this week so far, this is my third. No, this is Wednesday. I had 1 yesterday, 2 today. This is my 4th meeting this week, and it's a lot of time and effort, goes into it. But I do feel that there has been changes, a lot of changes in recent years. And NHS Tayside were one of the first to allow, the 4 public partners, to sit up at the table instead of just having, one sitting in the public gallery. So that was good. And Bernie and I actually go to a quarterly meeting of the Coalition of Carers in Scotland, which has the carer reps from all 31 integration joint boards in Scotland. And we all say what's going on in our IGBs and when things are positive and that Bernie and I put that forward as well. Perth and Kinross does this, and so I think it would be a step forward if we were to, do what Callum is suggesting there and Xander, and get a wee bit more recognition, and that again we would bring back to the national meeting and say this is what NHS Tayside are doing with their integrated joint board. So, thank you.
I appreciate that, Maureen. I'm now going to put my specs on here, Donald McPherson and then Ian McCartney.
We not got Sandra?
Yes, I was going to say with respect to Sandra.
Sorry, you're absolutely right. Sandra Auld, sorry, Sandra.
I didn't mind waiting. I didn't mind waiting at all. Thank you very much. It's again just to re-emphasise. Part of the ask here is around parity, and I think it was emphasised quite clearly. Some of the detriment that is experienced by not being a voting member, that we came across with the discussion around involvement in the appointment of the new chief officer, where just by dint of not being a voting member, we were being excluded from being a voting member on that group. And whilst none of this was the intention of how this role set out, that's the part of the reality as it is. The role has changed, the IGB has evolved, and my suggestion would be that the lack of parity needs to evolve along with that. And so very specifically on the back of what appeared to be significant support from the IGB to change that role, that we write as an IGB and try and drive this change in advance of whatever may come out of the National Care Service. And I think, and Ian can correct me if I'm wrong, but I think Ian's suggestion about a short life working group would fit in very well to Perth and Kinross contributing to the shape of the National Care Service. I think that might fit very well to make our voice more visibly heard or audibly heard. So I think that might work quite well. But because there aren't defined timelines for that, as I say, the ask is that we don't wait for that, and we move this agenda on specifically. Thank you very much.
Thank you. And to just pick up on that, I very much hear the urgency about this. And if we were to move to a short life working group, it would literally mean that, a short life working group, not a talking shop. Donald McPherson and then Ian McCartney, then back to Councillor Purvis.
Thank you, Chair. And I mean, I don't have the history of others on this topic, but I think I certainly welcome the discussion that's taken place and that's been prompted. I mean, what I would say is I've come across the role of the public partners in a number of different settings in the time I've been involved with the NHS Tayside and IGBs generally. I have to say that across all of those settings, I've found them to be committed, to be insightful, and to really provide a perspective that we would not otherwise have. So I think we need to recognise the important contribution that they provide. And, you know, clearly there is an issue around voting. I mean, I have to say it's not consistent across the various places where public partners crop up. So, for example, I chair the NHS Tayside Pharmacy Practices Committee, and in that setting, I, as chair, do not have a vote unless it's a casting vote, but the public partners do have a vote. So I don't think it's a question of some sort of desire to disenfranchise public partners as much as just the outcome of lots of individual piecemeal developments that have happened at different times. So, I mean, I don't think there's any reason in principle why public partners should not have voting rights. I think my only note of caution is that, you know, with rights come duties and responsibilities. And I think there are questions around appointment process, periods of tenure and accountability. Now, none of these are insurmountable, but they do need a little bit of time and care just to work through and get to the right answer. So, I mean, I think the issue for me, the voting rights, it was picked up in the Feely report. I think we can reasonably expect there to be some reference to extending voting rights in the National Care Service Bill when it emerges. And I think the right approach here is to take voting rights in the round rather than try and take a piecemeal approach here. I think, as Councillor McDade said earlier, we cannot change the position without legislation. My take on it is that legislation is already in train, and there's going to be a mechanism there to work through all of the issues, look at it in the round, and come forward with a sensible work through proposal. I think it's absolutely right that Perth and Kinross IGB should try to play a role in that process. I think the one the concern that I would raise is, I think, trying to set up, almost trying to fast track the issue by getting in ahead of the legislation with other legislation is likely to create more confusion and the risk of another piecemeal development. If the legislation, the National Care Service Bill, was not in train, I think I might well take a different view on that, and I think that there would be a need for us to move forward in advance of that. For now, I think my suggestion would be that we look to be ready to engage fully in the discussions around the bill. But as I say, I certainly, there is an issue here to be resolved.
Thank you very much indeed. I'm now going to go back to Ian and then Callum Purvis.
Thanks very much, Chairman and colleagues, for letting me have a second bite at the cherry. I never raised it in my original comments, but I'll do it now. In that I was in fact chair of the new body set up by the social care legislation in Parliament prior to 2010, and I applied through the public process and got interviewed and was appointed chair of one of the biggest health watches in the country. We covered 10 boroughs. We set up from scratch. Nothing's ever perfect. Ongoing relationships with councils and other bodies, developing them, improving on them, and they're now doing a review in England on the next stage in the role of local authorities in their health and well-being, which is basically an IGB in a different name, where all members of that from NHS, the local authority and the partners groups have voting rights, and it does work well. The reason I suggested this wasn't another committee, another meeting, another talking shop, but if you wait till the legislation's through and what's in the bill isn't quite covering everything, in the sense of you need to have a legal obligation placed on people to establish such a body, and give us an opportunity to look at both ourselves and also, more importantly, what we could suggest as a proposal or potential proposal to consider Scotland-wide in terms of the legislation. So we're not, and the history shows that these changes only take place when you get legislation. It's the only way of doing it. Or you end up, as a comrade said, you end up with it in a situation where it's piecemeal. That's no good. We really need to have a way and an agreement and what can be done now to improve, but as important, what we can do to influence the outcome of what will be the biggest change in health and social care, not just this short century so far, but before it, long before it. And so it's very important, I think, if we can come forward with a piece of work. And the previous meetings are committees. Well, one, there'll be different people, two, different situation, no crisis in the care home sector, no COVID and all the cuts and stuff. It's a completely different landscape to come to a discussion and agreement on the way forward, to be honest with you. And that's why I propose it, not just for the sake of it, but actually give appropriate time to coming forward with some ideas that I'm quite sure a few of us have got.
Thank you, Ian. I'm going to move to Councillor Purvis.
Thank you, Chair. And really just to reiterate some of the points that have been made by others, that I fully support the public partners in their role and think that they make a valuable contribution to the Integration Joint Board. And I think, as Maureen says, they bring their lived experience, their experience through their own what they've done in the past and their roles that they've been involved in, whether there was a formal or informal role. So I think that is very important, that we try to support them as much as we can. My view has always been, and I think it was the point made to us by Gillian Taylor, who was the former clerk to this board before Scott Hendry, that public partners are full members of the board. The only distinction is they don't have voting rights. And I think sometimes that we forget that, They are not included in everything. We have striven to try and change that. So things like the budget review group was previously restricted to voting members, and that's now been extended not just to public partners, but also to other non-voting members. And I think that's really important. But there are other areas where we have had agreement in the past that public partners would be invited. So that's things like pre-agenda meetings, where I don't think that is currently the practice. And I think that that's something that should be revisited, and certainly would have my strong support that public partners, at least one, is invited to those meetings, so that you know, like the chair and the vice chair being drawn from the two partner organisations at an early stage, can give their views into some of these proposals. And I think it is important that their voice is heard at that stage, rather than just only at the stage where we're making the decision, and perhaps that we would then be able to agree more things by consensus. So I would, you know, reiterate my support for that we should treat public partners exactly the same as we do voting members. They are full members of the board. The only distinction should be that they don't have a vote. And I would also add my support to the suggestion that the Integration Joint Board writes to the Scottish Government in advance of the National Care Service Bill being published, to you know, extend our support for that initiative, that public partners should have full voting rights. Thank you.
Thank you. Do you have any more contributors to this?
Yeah, I've had my hand up, or a comment for a while,
Yes.
Bob.
Sorry, Eric, they're just not coming through in my chat. Right, Eric, you go first, and who else is there?
Sorry, I think it's Pat as well. Pat as well.
Right, thank you very much, Eric, and then Pat.
Thank you. I as members know, I've huge sympathy for the situation in which the public partners find themselves in, and have long been supportive of change in order to equalise their status on the IJB. On the other hand, I have to say that the IJB is not a campaigning group. We're here together today to consider services to the people of Perth and Kinross, and to do our very best for them, and that's what's obvious at the forefront of all of our considerations. What I would say is that Bob and I have both attended meetings, and Bob is on the executive of the chairs and vice chairs group, the national group, and this subject matter has been raised in that forum previously. I think that in terms of getting change to legislation, that it is significantly more, it would carry significantly more weight were it to come from that national body that has direct access to the government ministers, and ministers attend that and seek input at these forums. You know, Bob and I, if nothing else, will hear loud and clear, and whoever may succeed me after the 5th of May will, you know, hear loud and clear the views of this board in this call, which is in public and is there for the record. And there is absolutely no doubt that we are supportive of the direction of travel here. And I think that is the way for us to you know, to actually put forward a motion to that group, potentially setting out our views, if these can be agreed in detail in the coming days and weeks, without diverting us from the key task of looking after the services. So I think that's the main prong of attack, as far as I can see, is through the chairs and vice chairs national group. However, there are things that that we can do and we could do right now to at least make positive change more than has already happened. And the suggestion from Councillor Purvis there is one such option, which is to just as NHS Tayside in the shape of Bob and Perth and Kinross Council in the shape of myself attend as chair and vice chair to the pre-agenda meetings. That we have had one-to-one dialogue with Sandra, I think, and Maureen in the past when we've had our one-to-one chats about a desire to shape the agenda. And I think we need to find a way in which we do that. You know, and if that is attendance at pre-agenda meetings or some other way, then fine. But I just want to conclude with one final comment, which is I don't think any of this was an intended situation, and I do think that the minister is sympathetic to what has been said already, and I'm hopeful, although I have no inside track, that appropriate change will be proposed in the legislation. I may be wrong, but in conclusion, I have actually been, no other word for it, but embarrassed by the two-tier status of the membership of the IJB. I just don't think it's right. I think that there are many things wrong with the integration scheme, but this is the thing that is so most obviously wrong that we need to do something about. So I'm very supportive of the direction of travel here, but I just think that the main conduit would be through the IJB chairs and vice chairs group. Thank you.
Okay, thank you very much. Now, I can't see it, but I believe, Pat, you wanted to come in, and then Councillor Duff, and then Beth Hamilton. And then I think I need to reach some kind of conclusion on this. Thank you.
Thanks, Bob. I don't think it'd be appropriate for me to comment on whether you need a working group or a group to look at this and what it would involve. I think events will be overtaken by the National Care Service, and that's a point that Donald made. I think that Scottish Government will make changes around this area from what I can understand. I have to say that we very seldom go to a vote, very seldom, and therefore it never feels to me like the public partners are anything but full partners of this IJB, and I can say that with a lot of confidence because they are challenging. They have a level of expertise which is unsurpassed in these areas. They speak for the users, they speak from people with lived experience, they bring a kind of down-to-earth, pragmatic and common sense approach. And I think it's been enormously valuable working with them, if I can say that, having been on this IJB for a number of years. I respect them hugely, and I think they've had an enormous impact on the decisions that we've made. I think we could get a bit hung up on the voting thing, and maybe people don't agree with me, but I think the really important thing is that we're listening to people and that we respond to what they say. And I think voting's less important. I can understand though if you're a public partner, you want to have equal rights and voting status. I can understand that. So I'm a bit less. Sorry, I've got a puppy in the background. I'm a bit less exercised by all of this, but I think it's been enormously valuable, and I'm fortunate enough to get to work with such high calibre public partners in my the next role. I'll be very grateful for that, but I don't think you need to. I think it will come. I don't think you need to. I don't think you need to instigate anything, but you know, I wouldn't be unsupportive of that if overall people felt that was the right way to go. Thank you. Let me have my say, Chair.
Okay, thank you very much. I go to Councillor Duff and then Beth Hamilton, and I note Sarah Dickey's comments before I go back to Sandra Alden. I would like to try and reach a conclusion on this, if I may. And Councillor Duff.
Thanks, Chair. I'll try and keep my comments short. I think it's been a very helpful discussion, and I thank Ian for raising this issue today. I'm very supportive of the principle, although I don't have the history on the IGB or previous discussions around about this matter. So, you know, personally, for my understanding, I think I would benefit from a process of consideration so that the issues can be teased out, if you like, whether that's a short life working group or a development session or both. I'm happy to leave that in the board's kind of decision, but you know, just to try and find the best way to move this discussion on. Thanks, Chair.
Okay, appreciate that, John. And as I say, I noted Sarah Dickey's chat on that. Sandra, I'd quite like this to be the final comment before I move to conclude this.
Thank you, Chair, and I'll be very brief. So I very much appreciate Pat's comments and her kind words. And she's absolutely right. There have hardly been any occasions in the time that I've been involved that there have been issues that have actually come to a vote. However, the issues that affect the public partners because we are not voting members. For example, there have been several instances where papers have been distributed and they have only gone to voting members. So those are the kind of instances that Pat and others wouldn't be aware of because they are voting members. And then the public partners find out about that we didn't get, you know, oh, we haven't seen that, we didn't get that. We didn't get that because we were not voting members. So it's the positioning with that status affords us or doesn't afford us that is part of the issue here. And again, I'm sorry to reiterate, but the situation a couple of weeks ago where we were automatically excluded from a role because we were not voting members. So it's to establish this parity. That's what we would like to do to enable us to contribute fully. Thank you.
And thank you. And we have to also think about the consequences if we don't move to that position as well, because I think there's an ongoing issue for us here that clearly has been raised through Ian's request with the public partners. And I think it's something that's incumbent on the IJB to help to move this forward. I think probably I would quite like the idea of a very short life come together and maybe one meeting or two meetings. I'm not too worried about the time scale of whether it's before legislation or not, but I do realise that when Councillor Drysdale talked about the use of the chairs and vice chairs exec group, they have direct access into National Care Service proposals and direct access to the Minister as a consequence of that too. So that could be done as well. I'm also mindful of what Donna was saying about there will also be other opportunities once the bill is published. But I see no harm in advancing this further than that. And I think also the other question that Councillor Drysdale said about not being a pressure group as such or a campaigning group, can't remember the exact words he used, but I do think that we can do things in-house now where I think the atmosphere and the timing may be absolutely right for making some of these changes within our own governance that could help to move some things forward. And we may need to look at, is remuneration a possibility? I don't know, that would need to be explored. I don't know what our powers are. But I do think that the points have been well made from public partners, and I would like to move it forward. And I was going to seek Jackie's advice because I'd actually started to meet with public partners in any case, because I recognise that this was going to be an ongoing issue. And Jackie, I'm wondering if you and I might chair or co-chair a very short, an initial meeting to scope out what we want to do. And I mean that initial meeting to happen sometime before the end of April, and to look at what we definitely would want to do both externally and internally as a way forward. And I'm kind of seeking your help on this to help me to take this forward.
Sorry, I've got a wee dog barking in the background there.
No,
no, yeah, I'm very happy to support you in that, Chair, and I'm thinking that the discussions that we had earlier in relation to engagement and your points about the relationship to the strategic planning group are key too. So I think an opportunity to explore all of that, and I'm happy to facilitate something and support that with you.
I suppose what I'm saying is that we wouldn't want to overload this with lots of people. Obviously, public partners would be there. I'd probably also welcome third sector rep as well. But I also wanted to pick up on, I'm just trying to get down to, Eric, are you trying to come back in again?
No.
All right.
No.
Okay, right, okay. Are there any other comments then? So are we agreed therefore that, I notice that Lynn Blair gives her thumbs up to this as well. Let's set up a short live working group, and I'm presuming the membership would be public partners. I'd like the other stakeholders to be there as well, actually, because I think it's important. But I would quite welcome at least having a voting representative as well from elected representatives as well as from NHS Tayside to be part of that conversation as well for continuity when we come back to eventually to the next board meeting, which will likely be in May, but hopefully we'll have produced quite a lot of the work by then. But that's what I would quite like. Now, we don't need to name individuals at the moment, but I would quite welcome other people to be involved in this too, if folks are content with that. That sounds as though people are content with that. So great, that's great. Thank you very much, Sandy. So I would like to therefore just accept the recommendation that we set about a short live working group to set out its own kind of terms of reference about what it wants to do externally and internally, and to have that with the public partners and the other two stakeholders. But I would also like, after this meeting, to see if we can get a nomination from another non-exec and elected representative, and Jackie and I will co-chair. I think that would probably work best, Jackie. Okay, thank you so much. I think that's, and I noticed some people are indicating their support for that. Thank you, Donald. Right then, okay, thank you very much. I think that was a very, very useful discussion. I'm so glad that we had it. And thank you, Ian and Public Partners, for elevating this discussion to this point. And I think we've got a way forward. Okay, that now takes me to the rest of the agenda. Would you believe it? 8.3 Audit and Performance Committee. Callum, verbal update.
Okay, thank you, Chair. Well, just to give you an update on the Audit and Performance Committee meeting that we had on the 7th of March. A number of things that we heard from or looked at the meeting, and we had one of our regular locality updates from the South locality, which was a very useful insight into the work that's going on by the partnership delivering services locally. And I was keen when we introduced those to ensure that we got a better understanding of the work that actually goes on the ground, because we are a service delivery based organisation, and while absolutely it's very, very important that we're on top of the finances and on top of audit and risk and all those other things, we do need to remember what our goals and objectives are. So it was really helpful to hear from them, and there's a lot of good work going on in the South locality, as there is in the other two as well. We had an update on the financial position for the year-end outturn to month 10, which was quite positive. We have an underspend of £767,000 at that point. And also there was some positive news on the Scottish Government funding. This was an issue that has been raised a number of times at different IGB meetings, but on the issue of slippage in savings, and the Scottish Government have now agreed to plug the gap and fund some of those savings slippages. So that was helpful. We also had some performance updates on with the key strategic indicators, and also an update on the partnership improvement plan. We looked again at the risk register, and there were a number of issues that were highlighted in that report. And there was an increase in the red risk from an increase in the leadership team capacity risk to red from amber. And also an increase in the corporate support risk from red, from amber to red. I'm getting myself tongue twisted there. And then also in inpatient mental health services, an increase to red from yellow. So we did have an extensive discussion around some of those, about some of the actions that are being taken to mitigate those risks. We also had a long discussion on a number of audit items. We appointed Jackie Clark as the Chief Internal Auditor for the next 3 years, a 3-year appointment rather than the 1-year appointments that we have been doing to date. And we also had an update on the audit strategy from a representative of KPMG about the work they're going to be doing in the coming year, and agreed the annual audit fee for KPMG as well. Now, we had the clinical care governance risk escalation report, which again is still in its early stages, and we were keen to have feedback from members on whether this was the right way of plugging that assurance gap that was identified previously. So there were a number of high risks that were identified, including in mental health workforce, and also psychiatry of old age inpatient staffing. And they set out some of the measures that are being taken to address those issues, including we've discussed earlier today, the older people's strategic delivery plan. There was another risk that was identified in December, which was over the community hospital staffing. Now that risk has been downgraded to an amber risk by the operational and delivery partners, but clearly the IGB still recognised that it is a risk to the delivery of our strategic objectives, and we talked about Pitlochry at the last IGB meeting. So there is still work ongoing to look at how the impact on the strategic objectives can be mitigated going forward. And then finally, we had the Chief Social Work Officer annual report from Jackie in her with her other hat on. There's always excellent work demonstrated by her and her team in that report, and it's always helpful and valuable to see it at the Audit and Performance Committee. So just to thank everyone for their attendance. You might not know, I've made the decision not to contest the election in May, so that was my final Audit and Performance Committee meeting. So I wish my successor well in that role, and thank all the members for their participation over the past few years. I think we have made some good progress on things like risk management and also performance reporting, and a number of other areas as well. So hopefully we're leaving it in a good position for the new team taking over after me. Thanks.
Thank you so much, Callum, and I'll thank you personally when we come to the end of the meeting. Thank you very much for that. Are there any questions to ask Callum on his feedback? If not, okay, we have papers for information 9.1 integration joint board reporting forward planner, which we produce every meeting, and you have the dates of future IJB meetings and future IJB development sessions as well. So before I close the meeting, I'd like to say a number of thank yous. First, I'd like to thank everyone who's produced all the paperwork today. So Jackie, you and your team, thank you so much for getting us to where we've got to today. I'd also like to thank public partners for getting us to, I think, an important place in terms of our considerations today. And I also want to thank those who are going to be leaving us. I'm going to start with Pat Kilpatrick. Pat, I know that you're not leaving NHS Tayside, but you're actually moving to another IJB. I'd like to wish you well with that. I have enormous regard for your focus on performance and analysis of data, etc. I think it's always been very impressive, and I think we're going to miss your contribution to that. And so I'll try and find ways of hooking you in another way, of course, because we're still sitting on another board, but I shall attempt to do that. Thank you. I'd also like to thank all of the councillors, and I'd particularly like to thank all the councillors, because I don't know after the elections whether any of the people will come back, whether they stand for election or not. Things change, and we could end up with a whole group of new elected representatives. So I wanted to thank all of you for that. It's been really interesting. I would say probably when I first came to the IJ about 3 years ago, I think probably I was almost mute with terror, I think was probably the best way to describe it, because it was just such a different experience of sitting on a board. And as time has gone by, I've very much kind of had to tune in much more into the conversations that we've had. So I've greatly welcomed that, and that's had a big impact on me personally and professionally, actually. I'd like to thank Sander and John. So I know that Sander and Callum are going to be leaving us in any case, so I thank you both for that. I'd very much like to thank you, Callum, for your chairmanship of the BRG and audit and performance. I think you've done that in an exemplary way, and I've really appreciated that as a chair and vice chair. And I'd like to wish both you and Sander well in wherever you go next with that. And I'd also like to thank those who I think may be standing again, but I'll know by 5 o'clock, Eric, I think. So I'd like to thank you, Eric, for your work to date, and particularly as chair, when we really needed some stability, I think, and leadership, and I've greatly appreciated that. And also your consistency with inclusiveness, which I think I've said before is one of your hallmarks. And I just wanted to thank you personally from that. I know that we'll meet again in some other guys, but as I say, it may or may not be on the IJB. I simply don't know. But I wanted to thank you and wish you well for that. And
thank you, Bob. And don't know where, don't know when, but I'm sure we'll meet again some sunny day. But I just have to add that I think that you may have been slightly premature in the valedictory for Councillor McDade, who is still with us.
All right. Well, I thought that he was, but thank you. Sorry about that, Sander. I seem to have misinformation.
As in still standing again. I mean,
all right, Chair. The people of Highland Perthshire may decide I am gone regardless. So we'll find out 5 weeks anyway.
Well, I'm not going to make any comment on that, given that I'm a constituent. Thank you. Okay, thank you so much, and we look forward to.
Could I just come in and say on behalf of the public partners, well, especially Bernie and myself anyway, a big thanks to Pat, and I wish her well, on her new Dundee's gain is her loss, I'm afraid, because she's been a good supporter of public partners and carers, and also to wish all the best to Eric and Callum and Xander, again, who have been a big support to us in that, and I hope we get councillors and reps that support us in the same way. So wish you all the best. And I just wanted to make sure that Bernie was recorded, that our apologies are in, because I was late getting into the meeting myself because of technical issues, and I just wanted to make sure that you had received their apologies. That's all. Thank you.
Okay. Thank you. Thank you very much indeed. And I look forward to seeing you all at the next meeting. And so thanks very much indeed. Thank you.